Good morning in Europe and West Africa. Good afternoon in East Africa. Good evening in Southeast Asia, and I think it's good night in America. Welcome to this session 2 of the LEAP conference, where we are going to discuss advances in R&D, access, diagnosis, and treatment of visceral leishmaniasis. My name is Dunya. I'm a clinical researcher, Center for Clinical Research, Kenya Medical Research Institute. And my background is internal medicine and epidemiology. I'm sharing this session with Dr. Yao, who is currently the Senior Clinical Project Manager for visceral leishmaniasis. Sorry, he's the head of Regional Clinical Operations in the DNDi Africa Region Office. He's currently in Accra, Ghana. Share the first 3 sessions while Dr. Yao will take the other 3. I'll later come back during the discussion time. So to begin with, we have some housekeeping rules, which we need to let the audience know. First of all, the presenters, we encourage that you have your cameras on when you are doing your presentation. We also encourage people to tweet and retweet. Remember our workshop hashtags, hashtag Leishmaniasis, hashtag African-Dara, and hashtag beat NTDs. All the questions should be put in the Q&A box, and they will all be addressed during discussion time. This conference is being recorded, and the presentations are all being recorded for those who will not be able to join us at this time, either online or physical. Now, without taking more time, I think we go straight to the presentations. And the first presentation is by Alexander Solomos. Alexander is a Senior Clinical Project Manager for Visceral Leishmaniasis Program, DNDi, and he's based in Geneva, Switzerland. He's going to present the phase 3 clinical trial, a more user-friendly option for children with visceral leishmaniasis. Alex, the floor is yours.
Thank you very much, Dr. Jane. Thank you. It's a pleasure to be here with you today. So I'm going to present you an overview of the phase 3 MFPM clinical trial, which represents a more user-friendly option for children with VL. So as you well know, VL is a global disease that is present in Latin America, Africa, Southern Europe, and Asia. But currently, Eastern Africa harbors really the highest burden of VL worldwide. There are 30 to 40,000 new cases estimated every year, and the disease affects mainly poor communities who live in remote rural areas and arid regions. A majority of patients are children, with the exception of North Ethiopia, where the disease affects adult migrant workers. And finally, this disease is very prone to outbreaks related to displacement of vulnerable population in case of conflict. Next slide, please. Thank you. So the current standard of care is for treatment of visceral leishmaniasis is the combination of SSG and PM. It is an improvement over the 30-day SSG monotherapy, but it still has some limitations. So the efficacy of this treatment is 91% at 6 months. It requires 2 injections per day for 17 days within the hospital. SSG harbors life-threatening toxicities such as cardiotoxicity, pancreatitis, hepatotoxicities. This treatment has shown a lower efficacy and a higher mortality in patients more than 50 years old. And finally, it is not recommended for HIV-VL patients. So the replacement of SSG by miltefosine has a potential to provide a safer treatment with the shorter hospitalization that would be suitable for children and better adapted to field conditions. So a number of trials were conducted in Asia and Africa to test paromycin and miltefosine treatment. And these trials show differences in response to treatment between these regions. So when we go in South Asia, the paromycin monotherapy at 15 milligram per kilogram per day for 21 days shows an efficacy of 94.6%. The miltefosine conventional dose of 2.5 milligram per kilogram per day for 28 days showed an efficacy of 90 to 94% in Asia. And when combining the two treatments for the same dose and a duration of 10 days, we could observe a very high efficacy of 97%. When testing the same regimen, same duration in Africa, this showed actually a poor efficacy. So same regimen and duration of paromycin showed an efficacy of 63.8% with a high inter and intra-regional variability that could not be explained by the paromycin exposure. And the miltefosine conventional dose showed an efficacy of 72%. When looking at the efficacy by age group, it was actually shown that the children less than 12 years had a lower efficacy. And this was correlated with the lower miltefosine exposure in this population, which was associated with a higher risk of relapse. So this regimen for the two drugs were adapted and tested in Africa, and they show an improved efficacy, and they were all as well tolerated. So when the dose of paromycin was increased to 20 milligram per kilogram per day for 21 days, the efficacy was increased to 84.3%, while the miltefosine dosing was changed, specifically for children to an allometric dosage based on weight and height, which represented approximately 30% higher dose for 28 days. And this resulted in an improved exposure and improved efficacy in children of 90%. So these two drugs with the revised regimen were combined in a phase 3 trial conducted recently that I will present. Next slide, please. Thank you. So we conducted the miltefosine paromycin combination phase 3 trial to develop a safe, efficacious, and field-adapted combination therapy for VL in Eastern Africa. This trial was open label, phase 3, randomized control, multi-center, and non-inferiority to compare the efficacy and the safety of miltefosine and paromycin with the standard of care SSG and PM. So the primary objective was to compare the efficacy of these two regimens, and the secondary objectives were to describe the pharmacokinetics profiles of the two drugs, to evaluate the parasite clearance in each arm, to assess the relationship between PK and PD measurements, and finally to assess compliance to miltefosine treatment in an outpatient setting. Patients recruited in this trial were confirmed primary VL patients between 4 to 50 years old, HIV negative, and who of course agreed to participate in the trial by signing the informed consent form. The sample size to be achieved was approximately 420 patients. So the trial was conducted in 4 countries at 7 sites: Gondar and Abdurafi in Ethiopia, Kacheliba in Kenya, Doka, Umerher, and Tabarakala in Sudan, and finally Amudat in Uganda. Thank you. So this is to show you the study roadmap. So the study was conducted over a period of more than 4 years. The first patient was recruited on the 18th of January 2018. Recruitment period lasts over a period of 29 months, and we had the last patients recruited in May 2020. So the patients were followed up for 6 months, and we had the last patient last visit occurring in December 2020. This last patient last visit was followed by an extensive data cleaning period with the database lock that occurred this year in August. And currently we are working on the final results analysis, and the CSR is expected to be available, to be finalized early next year. So as mentioned before, the recruitment started in January 2018 and was completed in May 2020 with a total of 439 patients recruited in the trial, despite the new challenges brought by the COVID-19 pandemic. When you look at the recruitment curve, you can see a rise in the recruitment from Q4 2019. And this was due to an increase in the number of VL cases in Sudan and Ethiopia, correlated to the high VL season, which had not been observed the previous year. And in addition, there was also the implementation of an amendment in the trial, revising the exclusion criteria in order to recruit a more representative VL of the population. When you look at the bottom right table, this shows the number of patients recruited by country and by arm. So we see the patients between the arm 1, miltefosine, paromycin 14 days, and arm 3, SSGPM is well balanced, 171 and 170 respectively, while the patients recruited in the arm 2 with paromycin, miltefosine 28 days is lower because this arm had been discontinued during the course of the trial. So looking at the repartition by country, we see the majority of patients were recruited in Sudan, 181 patients, followed by Kenya, 142, Ethiopia, 95, and finally Uganda with 21 patients. Next slide, please. So the baseline demographic characteristics are shown in this table. We can see that the majority of the patients recruited in the trial are children less than 12 years. They represent 60% of the trial patients, with the median age being 11 years old. There is a predominance of male patients in the trial, representing 80% of the trial population, as compared to 20% of female patients. This is compatible with the overall VL population, where we do see a majority of male VL patients. And finally, when we look at the repartition of male-female between the age group, we can see that the majority of female recruited are less than 12 years old, and this is also expected based on the general VL population, but there is also an additional limitation of the contraception that is required for a period of 6 months with the miltefosine because of the long half-life of the drug, and also the fact that the women who were pregnant or lactating were excluded from the trial. Next slide, please. So now moving to the high-level safety results. So the most common adverse drug reaction were expected based on the safety profile of the study drug. So these were vomiting related to miltefosine treatment intolerability, also injection site pain, and hypoacusis associated with paromycin. And also there were adverse drug reaction indicating cardiotoxicity, such as arrhythmia and QT prolongation related to SSG. So the majority of these adverse drug reactions were mild and moderate, and there were only 6 patients who had a treatment discontinued due to an adverse drug reaction. These were cases of arrhythmia, prolonged QT, severe vomiting, drug-induced liver injury, elevated liver enzymes, and hepatitis. Moving to the serious adverse events reported in this trial. There were 13 patients who presented 18 SAEs. 4 SAEs were considered related to study drugs. Among them, there were 2 cases of acute kidney injury related to miltefosine and paromycin, and 1 case of cardiotoxicity related to SSG that was unfortunately fatal, and 1 case of persistent profound bilateral hearing loss that was assessed as related to PM. This SAE, the patient who had this bilateral hearing loss also had an acute kidney injury event, and this could possibly explain the low clearance of paromycin and this unfortunate event. So this case was really exceptional. All the other hypoacusis event and hearing impairment were reversible, but it really revealed the importance of monitoring carefully the creatinine level during the course of the treatment. So there were also 6 patients, sorry, previous slide, please. Thank you. 6 patients had a fatal SAEs, unfortunate fatal SAEs. Among them, there was only 1 that was assessed as related to study treatment, and it was the case of cardiotoxicity related to SSG. And finally, 7 patients with SAEs recovered completely. So I'm not going to present you the detailed efficacy results today, but I can share with you that these are very promising, and that the new investigational treatment of miltefosine paromycin is showing a very similar efficacy to the current standard of care. So as a conclusion, the new treatment has been well tolerated with the adverse drug reactions that were expected based on the safety profile of the study drugs. If proven efficacious, this new treatment would reduce the use of SSG in Eastern Africa. It would reduce the treatment duration from 17 days to 14 days, and also importantly, remove 1 painful daily injection of SSG. This new treatment is more patient-friendly. It removes the cardiotoxicity associated with SSG. And since most patients are children, it has the potential to bring significant benefit. So currently, we are in the final stage of data analysis. The PK and qPCR analysis is also ongoing, and we expect to have a final report in January next year. So I would like to acknowledge and thank all my colleagues from DNDi who contributed and who worked on this project, as well as the partners and their staff who were key to the success of this trial. Thank you very much for your attention.
Well done for presenting results of a multi-center clinical trial, which has taken close to 4 years in 15 minutes. Let me remind the audience that we put all the questions in the Q&A box. We are going to address them at the end of all the session. We move on to the next presenter, Dr. Hank. Dr. Hank is head of Experimental Parasitology Group, Amsterdam University Medical Center in the Netherlands. Dr. Hank will be presenting opportunities in diagnostic and test of cure for visceral leishmaniasis in East Africa. Welcome, Dr. Hank.
Thank you very much for this introduction. Good morning, good afternoon, everybody. It's a pleasure to be presenting at this meeting. I will do my presentation also on behalf of Isra Cruz, who is unfortunately not available due to other obligations. I think so far we had a great meeting. It's a pity that we cannot be there in person to meet everybody, but I think this online event is also a very good alternative. So what I will do in the next 15 minutes is to discuss a little bit with you some potential new diagnostics that are available to meet the need for good diagnostics for leishmaniasis, both for visceral leishmaniasis as well as cutaneous leishmaniasis. And as we can see on this slide, in particular, if you look at the bottom, it is quite astonishing to see that a lot of people do not have a laboratory confirmation of their disease. In the case of CL, it varies from 25 to even 95%. And in the case of visceral leishmaniasis, it's around 30%, which is, of course, a very huge number of cases that are treated and may not have the disease at all, so they are wrongly treated, or they are mistreated, so they do not receive any treatment at all. Now, if you look at the top diagnostic priorities, we see that there is that in general strategies to improve access to early diagnosis and case management are really lacking. We definitely need an improved rapid diagnostic test for VL diagnosis, which has a good performance across the different geographies, because we know that there is quite a difference in the diagnostic performance of some rapid diagnostic tests if you compare the Indian subcontinent to East Africa. And of course, in the case of HIV positive patients who often lack a solid serum response, we see that some of these rapid diagnostic tests may be false negative. In general, if we talk about dermal leishmaniasis or tegmentary leishmaniasis, in which like CL, PKDL, and mucosal leishmaniasis, it would be very beneficial if we have a rapid diagnostic test available that could assist us in the diagnosis of this form of leishmaniasis. And test of cure of treatment for particular for visceral leishmaniasis, because it is, as we have seen in the previous presentation, often quite harsh treatment, would also be very beneficial to have. Next slide, please. If we now focus a little bit more on East Africa, we see that the situation is really worse for the continent. Again, the access to diagnostics and drugs is rather unreliable, and it is difficult to get those diagnostics and drugs really close to the people who need them most. The RK39 rapid diagnostic tests have a lower diagnostic performance in East Africa, at least compared to the Indian subcontinent. There are currently also issues with the availability of the RK39 rapid diagnostic test, so that also may makes the need for having an alternative available much more pressing. It is also difficult to successfully treat a VL patient in East Africa. We often see treatment failures, and whether or not this is related to drug resistance, I think that is still something that we need to consider. As previously mentioned, test of cure is difficult to determine for VL, and we often see relapses, the occurrence of PKDL, which may serve as a reservoir for the disease transmission. It's also needed to have good tests for that. Of course, with the rampant epidemics of HIV and VL co-infection, which is, for example, particularly high in Ethiopia, it also has severe implications for diagnosis and treatment. And in general, we lack a good point-of-care diagnostics for cutaneous leishmaniasis. And the situation has become even more complex due to the epidemiology of both VL as well as cutaneous leishmaniasis. For example, if you look at the situation in Ethiopia, where we see a lot of different co-infections with VL, but also different clinical manifestations of cutaneous leishmaniasis, like disseminated leishmaniasis caused by Leishmania or Ethiopica, it is really needed to have good diagnostic approaches in place. Well, on this slide that comes up now, we can see the three main diagnostic that are available for visceral leishmaniasis. I will mainly focus my presentation now on visceral leishmaniasis. Of course, for over 30 years, we have the direct agglutination test available. Still, to my opinion, being the most robust diagnostic test for visceral leishmaniasis, but of course with limitations due to persistence of antibodies after treatment and the relative long incubation time of 12 to 18 hours before a result becomes available. But still, I think the DAT, especially in its freeze-dried form, has its benefits. For example, you can obtain a titer, and with that you can also monitor progression of disease. The most often used alternative rapid diagnostic test is of course the RK39 test. I will come back to that one later. And of course, what would be very helpful if we could implement molecular biology like PCR in diagnostic settings, because PCR is one of the most sensitive diagnostic approaches that we have at hand now. But also the implementation of such an approach is difficult, especially in research-limited situations. If we go to the next slide, we see that in particular, RK39 test has a crucial role in the diagnostic algorithms that are being in place in East Africa. If a new case is presented at the clinic, then often a screening with a rapid diagnostic test, which is mainly the RK39 test, is being performed. And if this test is positive, then treatment is often installed. If the test is, however, negative, and that might be the case in many circumstances due to the lower sensitivity of the rapid diagnostic test, then we need to install the direct agglutination test, which can also help us to define further the decision whether or not to treat a patient. As said before, next slide. The RK39 test has its limitations, and by that it has become the Achilles heel of our diagnostic approaches. So we definitely need to find a new test that can help us to replace the RK39 rapid diagnostic test. One such approach, next slide, is the development of the RK28 rapid diagnostic test. This test is based on a fusion protein, so it's a recombinant protein that has both the K28 gene as well as K39 repeats in it. And this test has test based on the detection of antibodies against this particular gene have shown great promise as a new alternative diagnostic rapid test. And I will come back to that in a moment. Of course, next, also during the last couple of years, we have seen a great development in nucleic acid amplification test, and in particular in isothermal platforms, like the loop-mediated isothermal amplification test, the LAMP test, the recombinase polymerase amplification test, the RPA test, and the helicase-dependent amplification test, or HID test. All platforms have a huge advantage in the fact that they are quite robust, and by doing clever primer and amplification design, the test can also be very specific. What we also have seen is that they are quite tolerant to in-sample inhibitors, and also DNA extraction methods are quite simple. In most cases, just a simple boil and spin method is sufficient to obtain sufficient quantities of DNA that can be implemented in these isothermal amplification tests. Also, the readout methods, they are quite easy. It's often direct inspection of the sample that you have. So it is turbidity or fluorescence, and it can also be often being done in real time. So these isothermal amplification tests really provide a good alternative platform for PCR, which is requiring much more research infrastructure. So they may be considered as promising near diagnostic tests. In the next slide, we present the LAMP test. The LAMP test, it's been developed in collaboration between ICON, FIND, and my own laboratory, in which we have developed a test which is both able to detect cutaneous leishmaniasis as well as visceral leishmaniasis by having several different targets, so the kDNA mini circle as well as 18S RNA being targeted during the amplification process. It has a very high sensitivity, and the test format has been studied for cutaneous leishmaniasis in several countries, like Afghanistan, Colombia, and Suriname, and where we have compared its performance against microscopy and PCR. And there we have obtained very good sensitivity and specificity. The number of studies for the LAMP test in visceral leishmaniasis are less. There are some studies available from Ethiopia and Sudan. And also there we see a very good sensitivity and specificity of the test. And at present, the LAMP test is also being evaluated within the Africa DIA consortium, and also by several independent researchers, like for example, by the group of David Wolde in Ethiopia. So next slide. I already mentioned that the Africa DIA project has provided us a good platform to evaluate those new diagnostic tools for treatment of visceral leishmaniasis. And within this project, we have evaluated a new RK28 rapid diagnostic test for primary case detection. And we have evaluated the LAMP test also as a diagnostic test. Within this project, we have also been looking at different biomarkers. And unfortunately, that work is not fully completed and also not presented at this meeting. But I think the data that will come out of that will also be quite exciting to follow, as well as the development of an IgG1 specific ELISA and hopefully also RDT test, that's being done by the London School. And I think that are also very new approaches that definitely serve a platform in meetings like this. But okay, let us now move to the evaluation of the RK28 test, as was done in the Africa DIA project. Can you have the next slide? And then the next slide. Okay, here we see the preliminary results of the performance of the RK28 rapid diagnostic test in two different settings, in Kenya and in Ethiopia. In Kenya, we had 301 suspected VL cases, and in Ethiopia, 389 suspected cases. And as a reference test, we have used the VL diagnostic algorithm as it has been in place in Kachaliba Hospital. And we have assessed the performance of the RK28 rapid diagnostic test both on blood as well as on serum. Now, if you look at the number of VL positive cases as defined by the diagnostic algorithm in Kachaliba, we see that out of these 181 cases, if we use blood, we see that 176 were also positive by the RK28 rapid diagnostic test, and only 5 were negative with this test. Comparable results were obtained on serum samples, where we see 178 samples being positive with the rapid diagnostic test and 3 only negative. However, if you look at the non-VL cases, and that were 120 samples, we still see that quite a lot of them are found positive with the RK28 rapid diagnostic test. So that is really affecting the specificity of the test in this case, because if you look at overall specificities observed in Kenya, we see that it is on blood slightly above 70%, 71.7%, and on serum it's 66.7%. In contrast, the sensitivities are quite high and comparable to those of, for example, the DAT. However, if you look at the results we have obtained in Ethiopia, we see a slightly different picture. There the number of VL cases were much lower. We had 99 VL cases and 290 non-VL cases. But if you look in particular at how the rapid diagnostic test is performing on those negative cases, we see a huge number of false positive cases, both in serum as well as on blood. And that is also reflected in a very low specificity of the test. And that is really jeopardizing the implementation of this RK28 test at the moment in those settings, because with this high number of false positives, you may put people on treatment who are not having leishmaniasis at all. Of course, in next slide, we are currently looking into reasons why this RK28 test is performing less than we were expecting. One of the reasons is that we see a quite extensive amount of cross-reactivity with malaria, and that is also presented in this slide, where we see that in the case of malaria positive cases, the RK28 test is also quite often positive. Next slide.
Dr. Hank, can you summarize? Can you summarize? You have exhausted your 15 minutes, so can you summarize?
Okay, I've exhausted my 15 minutes. Okay, well, that's a pity. Well, the summary, the main outcomes is that the RK28 is probably not suitable as to replace the RK39 and that combination in the diagnostic algorithms available in East Africa. And as I said before, the RK28 is probably not suited due to its low specificity. And the direct occlusionation test remains a single serological test with sufficient high sensitivity and specificity for the serodiagnosis of visceral leishmaniasis in East Africa. I had a lot to tell about the LEAP test. Just briefly to mention is that test really shows excellent performance in the 3 countries where we have implemented the test, so both in Sudan, Ethiopia, as well as Kenya. We have observed a very high sensitivity and specificity, and we think that test may also be quite suitable for monitoring treatment outcomes. And with that, I gave the floor back to the chairman. Thank you.
Okay, thank you very much, Dr. Hank, and thank you for that presentation. Reminder to the audience to put all the questions and the Q&A box, and you address them at the end of all the 6 presentations. We move on to the 3rd presentation by Abigail. Abigail is a graduate student of the Kwame Nkrumah University of Science and Technology in Ghana. Abigail is presenting an investigation of the interactions of some anti-Leishmania natural compounds with potential protein targets and in silico approach. Abigail, the floor is yours. Go ahead.
Okay, thank you very much. Thank you very much for the opportunity given to me to present at the 2nd LEAP conference. So as part of my undergraduate study, I looked into Leishmaniasis, and these are some of my findings. Yeah. So Leishmaniasis is known to be endemic in 98 countries, and we have, Ghana has its fair share of Leishmaniasis, as there was reports in 1999 to 2003 in the whole municipality of the Volta region. So currently there was a study that was done by Akufu et al. In 2021 that outlined that there are suspected cases of Leishmaniasis in 3 communities in the OT region. Please, the next slide. Can someone move it to the next slide for me? Hello? Yeah, so in the, yeah, thank you. In the Leishmania parasites, as part of exploring what goes on and its way of surviving in the host cell, one of the important protein targets is Trypanatorium Reductase. So usually when the Leishmania parasite gets into the host cell, as a way of surviving in the host cell, it comes up with a substrate known as trypanotorium, which is reduced by Trypanatorium Reductase, and it's further used by another enzyme, that is triparadoxin peroxidase, to neutralize the hydrogen peroxide that is released by the host macrophages. And in the release of the reduced trypanotorium to triparadoxin, there are these amino acid residues that are known to play a key role in this. And I'd like you all to pay attention to these amino acid residues as well. Please kindly move to the next slide for me. Please, the next slide. So another important protein target that has been reported in the Leishmania parasites is Timberden Reductase 1. So the Leishmania parasites lack an important substrate, that is a growth substrate known as the bioterine. And as interesting as the Leishmania parasite is, it has come up with a complex mechanism that incorporates this bioterine, that is the substrate, into its mechanism of action. So Timberden Reductase 1 aims at reducing this bioterine that is known to be an important growth factor in the Leishmania parasite once it gets into its host cell. Please, the next slide. Now, looking into finding new therapeutics against Leishmaniasis, usually our first line of action is to go into nature. And these are compounds that have been reported in literature to have anti-Leishmania activity. However, these compounds cannot be optimized because their molecular targets are not known. So that means there is a derail in the optimization of these drugs as potential leads as well. So I think COVID-19 made us pay attention to computers. And please, the next slide. Pay attention to computers, and it has observed that computational tools have become very important in the drug discovery business. So molecular docking is a computational tool that is aimed in predicting predominant binding modes, usually of a small molecule and a macromolecule, sometimes of a macromolecule and a macromolecule as well. And in my work, I employed that too as well. So in my scheme of work, there were computational softwares that aided me in docking the natural products against the protein targets that were mentioned earlier on. Please, the next slide. So these are my compounds that were reported in literature that have certain level of in vitro activities. And these are the compounds that were prepared, that is, they were going to be modeled into 3D conformations, and various energy minimizations and calculations will be done to them before they were moved into the docking software. Please, the next slide. So the docking process involved the small molecules of interest, that is the natural products that have levels of anti-Leishmania activity against the protein targets of interest, that is Trypanatorium Reductase and Timberden Reductase. And out of the docking, these were the results that were observed. Please kindly move to the next slide. So these were the binding affinities that were observed when the natural products were dogged against Trypanatorium Reductase. We have Gibinol giving out a binding affinity of -7.6, and we have Citral not doing so well with a binding affinity of -4.2. I mentioned earlier that in the release of the Trypanatorium Reductase to be used by tryparadoxine, there are amino acid residues I told you to pay attention to, and I had some of my natural products establishing interactions with those of them as well. Now let's move on to Timberden Reductase 1. That's also established a binding affinity ranging from -4 kilocal per mole to -8 kilocal per mole. So in quest to provide information about how these compounds can be rationally optimized, and one of this is the identification of their molecular targets. These natural products, please move to the next slide. These natural products establish interactions either with Trypanatorium Reductase or Timberden Reductase, and further analysis that is using MD simulations are yet to be done to ascertain the stability of these compounds and to really be sure of the interactions that are made. And at the end of this, it's aimed to contribute to the rational optimization of these natural products as potential leads in the Leishmaniasis drug discovery development. Thank you very much. These are my references.
Abigail, you are a very good student. You kept time. You have even saved us some 3-4 minutes. Again, a reminder, all questions to be put in the Q&A box, and we address them at the end of the presentations. Now I hand over to my co-chair, Dr. Yao, to take us through the other 3 presentations. Dr. Yao.
Thank you very much, Dr. Mbia. The next presenter is Dunya Darif, who is a 4th-year PhD student in the Faculty of Sciences at the Anchok of Hassan II University in Casablanca, Morocco. Having graduated from the Faculty of Sciences with a master's degree in 2016, Dunya's PhD program began in 2018. Dunya is interested in Leishmaniasis research, particularly the immune response and therapeutic alternatives. The topic for Dunya's presentation is Caprispinosa inhibits Leishmania, major promastigote and mastigote growth through induction of nitric oxide production.
Well, thank you. So first of all, I would like to thank the organizers for giving me this opportunity to share our preliminary results of our works entitled Caprispinosa inhibits Leishmania promastigote and mastigote growth through the induction of nitrate oxide production. So Caprispinosa is the most economic species in Morocco, belonging to the Capridaceae family, and it contains a lot of biochemical compounds which exhibit a broad range of activities. So regarding the cutaneous leishmaniasis, it presents a major public health problem in Morocco with 2 main causative species, the Leishmania major and Leishmania tropica. The pentavalent antimonials are the main treatment recommended by the Ministry of Health in our country. Nevertheless, this treatment presents several limitations, including the therapeutic failures. Next slide, please. So the effect of Caprispinosa was poorly investigated, their effect on the Leishmania parasites. So the aim, our main objectives, were to analyze the phytochemical components of Caprispinosa, and after that, evaluate the effect on Leishmania promastigote and mastigote in vitro. So for this, the aerial part of Caprispinosa was collected in 2016, and after that, 2 extracts were prepared, including the methanolic and the aqueous extract. The total polyphenols and flavonoids were determined, and as well as the antioxidant activity using 2 different tests, which are the reducing power and DPPH test. The effect of Caprispinosa promastigote was and mastigotes was assessed using two tests, the trypan blue and MTT-SA, and the effect on the nitric oxide production was assessed using the PEACE method. Next, please. So in this table, we have the total polyphenols and flavonoids content in Caprispinosa extracts. So our results showed that the methanolic showed significantly higher amount of the total polyphenols compared to the aqueous. And in the terms of flavonoids, there was no significant difference between the both extracts. Next, please. The evaluation of the antioxidant activity of Caprispinosa extracts demonstrated that an important antioxidant activity for the both extract, but this activity was more pronounced in the case of the methanolic extract. Next, please. So concerning the effect of Caprispinosa, methanolic, and aqueous extracts on Leishmania major mastigotes in vitro, our results showed that the both extracts significantly inhibited Leishmania major in a dose-dependent manner, and the IC15 value for the methanolic was 25, and for the aqueous it was 100 microgram per milliliter. Next, please. So as the macrophages are the main target cells of Leishmania parasites, so we studied the effect of our extracts on the Leishmania and macrophagic mastigotes in vitro. So our results showed that both extracts significantly inhibited the Leishmania major mastigotes form in a dose-dependent manner with no toxicity toward macrophages. On the other hand, the nitric oxide production is one of the main leishmanicidal mechanisms used by the macrophages to eliminate the Leishmania parasites. So for this, we analyzed the production of the nitric oxide production in macrophages incubated with different concentrations of both extracts in the presence or absence of the Leishmania promastigotes. So our results shows that both extracts induced the nitric oxide production, and we noticed, interestingly, that the aqueous extract increased the production of nitric oxide in the absence of Leishmania major infection. Next slide, please. Thank you. So to conclude, I can say that our phytochemical analysis of both Caprispinosa extracts showed different content in polyphenols and flavonoids, which differs from the content observed in other regions of the world. And these variations could be related to the plant part use, to the geographical conditions, the biotopes, the seasons, and also the extractions methods. Furthermore, we showed our extract demonstrated an important antioxidant activity and also a promising leishmanicidal activity on the promastigotes forms of Leishmania major, as it was also previously reported in other studies. And also we saw that our extract showed a promising leishmanicidal activity in the intramacrophagic mastigote forms of Leishmania major through the induction of the nitric oxide production. And to our knowledge, this is the first preliminary report in the mastigotes forms of Leishmania major. So to conclude, I can say that this finding showed that Caprispinosa could be a valuable source for new biomolecules for the treatment of Leishmaniasis, which enlarge the panel treatment. And these findings will be confirmed by complementary studies. And thank you for your attention.
Thank you very much, Dunya, for your presentation. Please remember, if you have any question, you can go into the Q&A chat and put your questions there so we can answer them at the end of this. Thank you, Dunya. The next presenter is no stranger to LEAP. This is my colleague, Simon Bolo, Regional Operations Leader, DNDi Africa Regional Office. Simon is head of finance, administration, and operations function of the Nairobi office. He also takes the lead in the development, implementation, and evaluation of Nairobi office strategy and annual action plan. He has offered financial and administrative support to various clinical trials and multiple therapeutic areas within DNDi. Simon joined DNDi in 2005 and has 20 years experience in financial administration. Prior to joining DNDi, he worked for Handicap International for over 6 years. Simon has been able to develop and implement a standard for financial reporting or good financial practices for DNDi, implementing partners across the region, as well as developing simple financial tools for non-finance professionals to assist in financial reporting. He has also been instrumental in the implementation of a quality management system for the Nairobi office and leading the office to certification of ISO 9001, 2008, and 2015 standards. Simon holds an MBA from Strathmore Business School of Strathmore University and a bachelor's degree BS in International Business Administration from the United States International University in Nairobi. He's a qualified accountant of Kenya, a CPA, and he's also a certified Mango finance trainer. Simon will be discussing financial and administrative challenges in clinical trial implementation in resource-limited settings, experiences from DNDi-sponsored clinical trials in Eastern Africa. Over to you, Simon.
Thank you very much, Yao, for that opportunity and introduction. Just to give you a background on this paper, we have been conducting clinical trials in Eastern Africa since 2003, and in most cases, the sites were in remote setting with limited resources. In 2007, after setting up the good financial practice training, we were able to hold our first workshop in Nazareth, Ethiopia, for the LEAP partners. This is a training that offers a guide and to effective and efficient financial administration for clinical research, and it has 4 main modules covering budgeting, forecasting, accounting, and reporting and monitoring. We've since held 5 GFP workshops across the region, training of 100 participants from LEAP membership institutions, as well as one-on-one training at partner sites on a needs basis. We've also offered the GFP training to non-DNDi related clinical research, 2 of them organized by CREATES and FCD, and the other 2 were offered by CleanWin Research. Next. So the objective of this paper was to describe the challenges, financial and administrative, that has been experienced in the conduct of clinical research in resource-limited settings in Africa, and to provide recommendations that may have a positive impact in the future of clinical trials conduct in resource-limited settings. The methodology we used was to collect qualitative data on key success factors and challenges, mainly through observations, focus group discussions, case studies, and literature review. We collected data during the various GFP trainings that we held, during the site visits for either review or financial audits by DNDi finance teams, during the communication exchanges between sponsor and trials, and from clinical trial agreements, negotiations, as well as from the reports for the financial, from the partners' financial reports, as well as clinical trials. Now, just to put things into perspective, over the years, for the last 5 years, we've been working with about 25 partners and invested just over 6 million euros. Next. We've captured the results in three major areas. One is sponsor-related challenges. The first one is the inadequate funding. The nature of the disease that we work in, basically neglected tropical diseases, leads to prioritization because we do not have enough resources for NTDs. There are also skewed arrangements in terms of the contractual arrangements with the partners. The payment milestones that are included in the clinical trial agreements sometimes do not take into consideration the implementing partners' realities on the ground. We don't allocate enough funding for finance and admin teams, mainly because of the prioritization. Sometimes this used to lead to the clinical trial teams handling financial and administrative tasks, which is not their area of expertise. Fund transfer delays, which in part are due to either political issues, issues related to implementing partners, or internal policies at the sponsor, impede clinical trials. We also found out that internal policies at the sponsor sometimes affect the conduct of the clinical trials. So, for example, certain financial or finance procedures need to be aligned to the local context. An example is the travel policies that we would have at the beginning, which we ended up adapting for the reason that certain areas where we work in, you would not even be able to get a receipt to justify the expenses when you travel. The second part of the results is around implementing partners related challenges, one of which is bureaucracies at the partners. Processes at the implementing partners sometimes hinder efficiency. There are very lengthy procurement processes, which leads to delays in purchase of clinical goods and services. For example, I remember in Malawi, we had to coordinate the purchase of a motorbike to be used in the field in Malawi from Nairobi. The similar examples have been experienced in places like Sudan as well as Ethiopia. The HR capacity for financial administration at the partners is usually quite low to meet the financial management and reporting expectations of the sponsor. Sometimes the admin staff do not fully understand the needs of the clinical trials. For example, we have experienced cases where the finance staff have curtailed the budget for, say, nutrition or food for clinical trial or for VL because they feel that the other patients, non-VL patients, are not getting food, while the needs of such a clinical trial requires that the patients take food alongside the medication. Here, a point in case is miltefosine, which has GI-related complications that requires that the patients take food before they are given the medicine. Lack of due diligence also during the clinical trials agreement negotiation has led to non-adherence to agreement requirements. We've experienced quite a lot of high staff turnover at implementing partners. Sometimes reassignment of staff at ministries of health end up affecting the conduct of clinical trials. The capacity of the systems in place at the various partners are also not very adequate to be able to allow them to handle certain tasks that is expected of them. For example, most of them lack computerized accounting systems, and this is something that was once cited by EDCTP during an audit, as they did, the implementing partners did not have the right tools to perform their jobs. Lastly, on the results, the environment-related challenges, we've experienced political issues, instabilities that make travel impossible, bureaucratic systems and embargoes make funds transfer extremely difficult and sometimes impossible, and this delays the conduct of clinical trials. The infrastructure in where we work in, first of all, is not very attractive because to go and live in those areas, increase the cost of clinical trials. Sometimes we need adapted vehicles to be able to go through the terrains that we work in. And the procurement and shipment takes longer than necessary because of the terrain that we are working in. The legislative issues such as visa requirements, changing custom requirements, sometimes with very stringent documentation requirements, delay clinical trials, and as a result, shelf life of commodities end up expiring. Lack of commodities in the countries where we work in due to disruptive supply chain, equipment plus essential commodities are not available in the countries, leading to import, which causes delays and increases the cost of clinical trials. Lastly, hyperinflation, exchange rate controls increase the cost of clinical trials conduct, and in certain cases we realize that it makes it very unattractive for suppliers to be able to do business, because most of the supplies that we use in clinical trials are imported, and because of lack of attractive exchange rate, then it becomes impossible or unattractive for the suppliers to do business. In conclusion, I think we've come to realize that finance and administration systems are quite essential for the success of any clinical trial. Finance, the bottlenecks related to the same seriously impede the ability of studies to run smoothly, often causing delays and increases clinical trial costs. Unfortunately, these aspects are often overlooked in discussions around what impedes clinical research and what is needed to strengthen research capacity in Eastern Africa. A good financial knowledge builds financial trust between partners and improves relationship for the success of clinical trials. Good financial practice we've come to realize provides a very good basis for improving and sustaining the financial and administrative capacities of partners. And effective collaboration certainly builds sustainability because there is trust amongst the partners. Next slide. Our recommendations are 11 and include one, we'd want to see an inclusive kickoff for the various projects that are being implemented to ensure participation of both sponsor and partner financial admin team so that they're able to understand the requirements of the project, of the clinical research, and to also align and define roles and responsibility. This would certainly help in reducing the likelihood of unforeseen expenditures. Preparedness and adaptability, the areas where we work in requires that the sponsors are quite prepared and adaptable to the situations that keep on popping up every now and then. We have areas where the key human resources are reassigned, or there's political instability. I think it would be important that even our protocols are made to be adaptable to such situations that makes it easier for us to move and conduct clinical research in a way that responds to the issues that arise on the ground. Allocating resources for the finance and administration personnel is very, very important, as we've learned. This, other than achieving efficiency, will also allow the clinical trial staff to concentrate on their core deliverables, which is to conduct clinical trials and letting the professionals handle finance and administrative issues. GFP needs to be positioned the way GCP and GCLP have been positioned, such that before the conduct of any clinical trials, the related personnel must undergo a training or a refresher so that they're acquainted with the requirements of the trial. Capacity building needs to be engaged in a sustainable way to equip the implementing partners with adequate capacity to handle donor financial obligations. This way, the sponsors sometimes then would reduce the tasks that they're supposed to conduct. And we've seen situations where certain donors require that it is the implementing partners that provide the financial reports directly. Next slide. We need to have a more responsive mechanism for budgeting and funding. that understand the challenges that are being faced during clinical trials. In most cases, you realize that admin costs are always lumped in under overheads, making it very difficult to allocate funds for the finance and administration function. The need for risk ownership and sharing between the partners so that everybody is on an equal footing. We should ensure that the implementing partners equally take study ownership by being responsive to their needs, by having long-term partnership that they can be able to see the horizon of the projects that we are running. There's need for increased partnership, even as we engage clinical trials related partners. We also need to think through the continuum of partnership in clinical trials, and probably include the likes of the customs authorities, the revenue authorities, who sometimes create bottlenecks that hinder the success of clinical trials. And also, as we do our advocacy work, we need to rethink and include both upstream and downstream partners who are likely to expedite the supply chain of the clinical supplies that we use. Enhanced communication is very key, especially in this digitization era. We need to share digital platforms with our partners so that they are able to provide us with the reports as fast as is possible. A case in point is, for example, DNDi that has a platform called SharePoint can easily give access to the partners to be able to share information at a much faster rate. And lastly, strategic partnership is very, very important for collaboration, and to ensure we should ensure that we develop long-term strategic partnership which builds a trust as the future will be clearer for both parties involved in the clinical trials. Just need to acknowledge all the LEAP partners and sites that we've worked in, and the other partners in other therapeutic areas, including mycetoma, heart, rhodesiense, pediatric HIV, anti-CoV partners, where we derived all these experiences from, not to forget my fellow co-authors, as well as those who contributed by reviewing this paper. Thank you very much.
Thank you, Simon. Reminder, please, if you have questions, put it in the chat and we'll look at it later. And the last but not the least speaker for this session is Praveen Dal. Praveen is a research fellow based at Infectious Diseases Data Observatory, Edo. He has a broad interest in epidemiology of malaria and visceral leishmaniasis. His research has primarily focused on delineation of dose-response relationships for commonly used anti-malaria drugs through individual participant data, meta-analysis, and assessment of safety of anti-leishmanial drugs. Prior to joining Edo, Praveen obtained his PhD on investigation of statistical issues in design and analysis of anti-malaria clinical studies. The topic for his presentation will be progress made on the VL data platform and plans. Thank you.
Thank you very much, Dr. Yo, for the nice introduction. And I would like to thank LEAP for this opportunity to present about the VL data platform and provide an update on the progresses made and our future plans going forward. Next slide, please. Thank you very much. So for those who are not familiar with Edo, Infectious Diseases Data Observatory was established roughly 10 years ago, primarily to work on malaria. And it is a group of scientifically independent researchers working together to answer research questions of interest on infectious diseases and emerging infections. Edo actively maintains database of clinical studies with the aim to reuse this data sets and database to generate new evidence and subsequently drive policy changes. Next slide, please. And Edo currently actively works on 8 different diseases areas, including visceral leishmaniasis. So we work on malaria, medicine quality, Ebola, febrile illnesses, COVID-19, and soil transmitted helminths in schistosomiasis. And we are currently building on the building phase of the database for these 8 areas of research. And today I'm going to present about visceral leishmaniasis. Can I get to next slide, please? Next slide, please. Thank you very much. So, so the VL data platform, it started nearly 5 years ago with a collaboration between Edo and DNDi, where we looked at scoping review to identify what is the existing base of the evidence deriving information on visceral leishmaniasis drug safety and efficacy. So in order to answer that questions, we started carrying out a scoping review and identified publications on visceral leishmaniasis from 1980 onwards. And the overall aim was to answer the questions: is it feasible to create a data platform on visceral leishmaniasis? And next slide, please. And that review began in 2016 and identified just over 150 publications. Is it possible to get to the next slide, please? Yep. Yep, thank you very much. So the review began in 2016, and we conducted this review to identify any publications. And after the initial publication in 2017, the review has been updated continuously. So we update the review every 6 months, and all the records identified during this review is made publicly available through our web browser. So researchers all over the world can look at this resource and try to answer any particular research questions of their interest using this review database. Can I get to the next slide, please? And currently, the last review, the revision of the review, have identified nearly 160 trials. So there are 158 trials in total, with just over 35,000 patients enrolled in these studies. Thank you very much. And majority of the studies identified in this review comes from the Indian subcontinent, followed by East Africa, and some of the studies in other regions. Next slide, please. And the common observations from this review database is there is a large, next slide, please, thank you. There is a large heterogeneity in design and conduct of these studies. So even within a drug regimen, so suppose antimonial drugs, there are so many variations of the antimonial regimens in terms of duration of the treatment, the target dose that was used. So there is so much heterogeneity in the conduct and design of their studies. A large number of the studies had a typical small sample size. So that means the number of failures in any particular study is going to be very few, and that limits us to reliably identify any risk factors for treatment failures. So these are the sort of common challenges we found when looking at this review database. Next slide, please. So the conclusion of the review was an individual patient data repository will be able to overcome some of these challenges, and it is feasible to establish such a data platform. And the focus of Edo in collaboration with researchers from the VL community has been to establish this data platform, and this has been ongoing for the last 5 years. Can I get to the next 2 slides, please? And next slide, please. So the Edo, thank you. The Edo VL platform has been in active phase of development for the last 4 years. So this graph describes the process which Edo uses in order to standardize the data. So researchers who conducted the trials identified from the systematic review were actively requested to participate in this collaboration for the development of the data platform. And once researchers agreed and uploaded the data, it was standardized into a common format using the CDISC data standards. And on the left-hand side of the graph here, the researchers could share data in any format, so that the format of the data could be heterogeneous in terms of the file types, in terms of the study designs, in terms of the characteristics of the studies. And all this data, heterogeneous data, is standardized using this common CDISC standard and stored in a safe repository. And this standardization takes place in close consultation with the primary investigators who shared this data with Edo. Can I get to the next slide, please? And currently, the Edo Data Repository has 45 VL studies that has been standardized using this CDISC format, and it has taken a long time, and it has been a huge effort collaboratively among all the VL researchers to develop these standards. And these studies that are currently in the repository, that they describe nearly 14,000 patients, and that's nearly a third of the all published sample size identified from the systematic review. And there are currently additional studies that are waiting to be standardized, including studies on PKDL patients as well. And the inventory list of the studies that is currently in the repository can be available through our webpage. So investigators who are interested in answering a specific research question, they can visit the inventory and identify whether these data sets are sufficient to answer a particular research questions of interest or not. Next slide, please. So the conclusion of the sort of the repository that we have held is that Edo has, in collaboration with the global research community, has assembled a critical mass of data, and this gives an unprecedented statistical power to answer research questions of public health importance, which would otherwise not be possible to answer using a single study, a single clinical trials. And there are several examples of the research questions identified by the research community, and Edo again had facilitated a development of the research agenda that lists all the research questions identified as being important to the VL researchers. Next slide, please. So the VL research agenda was developed about 3 years ago, and it has different phases, and researchers were requested to identify any questions that they would like to answer using this database or in general. And there are more than 50 research questions on this document, which is available through the link at the bottom of the slide, and some of the examples of the research questions are: can we characterize the hematological profile of the patients during the treatment and the follow-up period? What is the optimal duration of the study follow-ups required to capture treatment failures? And can we identify risk factors for treatment outcomes? So investigators who are interested in using this database can identify research questions of interest from the research agenda and can make an application through the Independent Data Access Committee, and the Independent VL Scientific Advisory Committee will review these questions and approve whether appropriate or not. Can I get to the next slide, please? So so this is our VL Scientific Advisory Committee, which is currently headed by Professor Chatterjee, and includes researchers, VL researchers from all over the world. Next slide, please. And the data platform, I'm going to give update on the 2 research study groups that is currently undergoing using this data hosted at the Edo VL platform. The first one is regarding efficacy of the drug, which aims to answer the research questions on identification of the host drug and parasite risk factors that affect early and late therapeutic responses. And the study group is currently looking at risk factors for initial failure, initial cure, and subsequent relapse at the end of the study follow-up. So this is being taken in collaboration with our fellows from ICMR. Can I get to the next slide, please? And the next research question that IPD, the individual participant data meta-analysis, is looking at the safety of the drugs, in particular the hematological safety of the drugs. And the research questions are to describe the hematological profile and anemia at presentation during the treatment phase and during the post-treatment follow-up period. And if possible, to quantify how much of the hematological fall at baseline could be attributed to the disease itself. And again, this is being undertaken currently in collaboration with our colleagues all over the world. And next slide, please. So it's not only sort of reuse of the data to generate new evidence, but Edo has been also working towards generation of the sort of development of the harmonized protocol for prospective data collection. So this is a workshop that was conducted in 2020 that led to the sort of development of a CDISC compliant case report form for uncomplicated VL. There were collaborations between DNDi, WHO, MSF, FDA, and other pharmaceutical industry as well. Can I get to the next slide, please? And the CRF is now publicly available from the Edo web page and is currently being utilized by DNDi for some of the trials. And Edo now is working with collaborators and colleagues from ICMR, MSF, and DNDi to develop a new CRF specifically for VL HIV co-infection. Next slide, please. And this slide sort of answers the potential of utilizing the data hosted in the Edo repository. For example, we know relapse is very difficult to identify, especially when suspected cases of relapse would have to undergo further bone marrow or bone marrow sampling. Aspirates should be taken to confirm the relapse, and this project is aimed towards identifying a clinical prediction algorithm that can identify patients at an elevated risk of being a relapse patients. So the aim is to sort of minimize the number of samples that is needed to be taken, so that we can reliably identify those at a higher risk of relapse, so that we can avoid taking unnecessary samples. And there are nearly 5,000 patients with 203 relapse from 12 studies that had parasitologically defined relapses, and using a sample size calculations, and it was assessed that this number is enough to reliably to develop a new clinical prediction algorithm, and this has been planned for future. Next slide, please. And also sort of work is ongoing on PKDL, so a systematic review is currently being undertaken. And as a next step after the PKDL review is complete, the review will focus on ophthalmological outcomes in patients post-PKDL treatment. And this is in collaboration with Dr. Pandey and Dr. Siddiqui at RMRI and Dr. Singh, who is currently working with us. Next slide, please. So to summarize, Edo VL Data Repository has reached a critical mass of data. So that's just about a third of the published sample size identified from the literature review. There are further studies that are being curated for VL and also for PKDL. The Edo Data Platform is currently supporting 2 IPD meta-analysis to answer research questions that has been identified by the VL community as a part of the research agenda, and also been approved by the independent Edo Scientific Advisory Committee. And we're working on the living systematic review, continually updating it every 6 months, and the library for PKDL studies would be also made available upon completion of the review. And there's further work ongoing to establish the data platform on PKDL, and also development of the case reports form for VL HIV co-infection studies. Thank you very much for listening. Thank you very much for this opportunity to present. And I'd like to acknowledge all the members of the EDVL team and our partners with whom we are all working together for the development of this platform. So thank you very much.
Thank you very much, Dr. Praveen. At this stage, we've come to the Q&A, and I'll turn it over to Dr. Mbui.
Thank you very much, Dr. Yang. We have, I think, only 10 minutes for Q&A. Fortunately, most of the questions, I think, have already been had in the Q&A, respective presenters, but we do have still, I think, 2 questions also which have not been answered, and they are both directed to Dr. Dunya. The first question I'll read for you. Thank you, Dunya, for your presentation. What is the reason to plan your experiment to use methanol and aqueous extracts that have close polarity rather than non-polar solvents, e.g. hexane? Dunya?
Okay, thank you for the question. So what we have done is that we have done a test before our study. We examined like determined the compound using different solvents, including the acetonic and also the ethanolic and methanolic and aqueous extract. What we have, what we noticed that the metallic, and what I just include in my presentation, the methanolic and aqueous, that we have. We saw that the methanolic presented the highest amount of polyphenols and flavonoids, while the aqueous, in the other hand, the aqueous was the extracts who showed the lesser amount of polyphenols and flavonoids. This is the reason why I just chose they chose just the methanolic and aqueous.
Okay, thank you for your response. The second question is still for you. Have you tested whether inhibitors of nitrous oxide production also inhibit the leishmaniasis activity of the extracts in infected macrophage to confirm the role of nitrous oxide?
Yes, this is a really good question. What we have done, we tested, we incubated the macrophages in the presence of the inhibitor, the NMA, and but in the absence of the Leishmania pumasigot. What we have seen is that in our that the inhibitors, when we add the inhibitors, there was no production of nitric oxide production, but we didn't test it with the presence of Leishmania major pumasigots. But we have done also another test, which was in silico. We saw that our extracts, after identifying the components of our boat extract, we saw that after running the docking, that our extracts binding perfectly to the arginase. When I say the arginase, it's an enzyme used by the Leishmania parasites, and it uses the same substrates that use the inos to produce the monoxide, the nitric oxide. The arginase in our compounds bind perfectly to arginase, which say that they inhibit perfectly the arginase.
Okay.
But I will take this in considerations. Thank you for the question.
Okay, thank you, Dunya. Dr. Praveen, there's a question for you. Do you think a method expert should be in your expert committee? from somebody, Jane.
Yeah, thank you, Dr. Jane, for these questions. Yeah, I think we should, but I think we are very, very lucky to have a VL research community who have been working on design and analysis and on VL research for a very long period of time. So we are very fortunate at Edo to have a wonderful scientific advisory committee, but really taking point that a lot of methodological questions can be answered using this database. So I think it would be also important to have a methodological expert and in particular on different aspects of the disease. So thank you very much for these questions. So yes, the answer is yes, but we are very lucky to have a great scientific committee who come with a lot of experience on different aspects of the trial design and maybe not necessarily statistical methodological expertise, but in terms of clinical methodological expertise, we are very lucky to have the team. Hopefully
Thank you, Dr. Prabi. Thank you.
Thank you.
Anyone on the floor of physics?
Hello.
There's no one asking a question, and I think there is no other question, Joy. Yeah, all the questions have been responded. Thank you very much to the
I think there's
presenters,
one more question.
the audience. You are great. And
Jen, I think
there's
there's one more question.
There's one more question. It was directed to Dr. Abigail Adumaku, but I think it's for Dunya. Are your target proteins keeping the activity or biological activity within the mastigote from parasites? This is from anonymous attendee.
Can you please repeat the question? I didn't hear it well.
Are your target proteins keeping the activity or biological activity within the mastigote from the parasites?
Did
you hear that?
No, I didn't hear you well.
Oh, I'm sorry. Okay, it says, are your target proteins keeping the activity or biological activity within the mastigote form of the parasites?
I didn't get the question well. Is that my target protein? If we target the protein, we can inhibit the Leishmaniasis activity on mastigote. This is the question?
I believe so. If you can look into the chat, there's a question there which was sent look at the answered questions, because okay. Abigail said, kindly come again. And I said, this question should be directed to Dr. Dunya. Can you look in the chat to see if you can see it, since there's connectivity too? Yeah.
Do you mind commenting on the? Okay, meanwhile, as Abigail is looking at the response, I think there's one more question from Dr. Prabin. Excellent database, Dr. Prabin. Would you mind commenting on the back edge you use? Whatever that is.
Thank you very much for this question. Unfortunately, I'm not technical to answer questions on the informatics side of the database. So sorry, I don't have a good answer to that question.
Okay, and I think that's all. I can't see. Dr. Yao, can you see any other question? We can't see any other question.
I can't see any more. I think all of them have been answered, except the one that we just talked about.
Okay.
Everything is answered, yeah.
Okay, with that, we come to the end of this very exciting session. And we want to sincerely thank the presenters for their excellent presentations. And they have already responded to the answers to quite a variety of questions which have been raised. And so now we immediately, I think, I don't think there's any break. Don't see any break. Unless people want to stand up and stretch, the ones who are here physically. Otherwise, we now move to session 3 in the next maybe 5 minutes or so. So thank you very much. And we come to an end to this session 2 of the LEAP conference. Asante sana. Over to you, Aslat. The ones who are here, you can stand up because I think people may end up dozing. And you breathe in and out.
It is a form.
Of course, with their masks on. Simon?
It's like in Kenya, the cure.
Simon? Masks on in the room, masks must be on. Unless you are drinking water.
Monday.
Oh,
yeah. Yeah, I think that is.
Yes, sir.
Yes, you can stretch and avoid DVT clots. Okay, over to you, Professor Asad, for the next session. Thank you, audience. Remain online. We still have another session and also posters. They were saying, Professor, this is better.
Oh, this thing?
Yes.
Okay.
So you may need to move.
Okay, it's about time to start. So I ask everyone to take your seats and we'll start with the next session. The next session has 4 oral presentations and also poster presentations as well. So bear with us. And I would like, yes, that's good. I see my co-chair, Dr. Esther Kingeru. I would like, first of all, to introduce my co-chair, Dr. Esther Kingeru, who is a public health specialist. She is currently the focal person for cutaneous leishmaniasis and other entities in Nakuru County, lauded for initiating a treatment for CL patients in Kenya. She has a great passion for fighting, for patients affected by CL. She is a national trainer for both visceral and cutaneous leishmaniasis, and she has partnered with various organizations, nationwide training and in conducting surveillance activities in VL endemic areas. Esther played a very instrumental role in the development of Kenya Leishmaniasis strategy 2021 to 2025, and she's actively following through its implementation. She has a vast experience in diagnosis, treatment, prevention, surveillance, monitoring, and evaluation of leishmaniasis. Dr. Esther would be co-chairing, and her experience is an input to this session. Perhaps I will take up the first 2, and Dr. Esther would take the next 2, and so on. We will proceed as such. So I will start with the first speaker. So Dr. Murad, Mokni is a professor of dermatology in the Faculty of Medicine of Tunis, University Al Manar, and head of the dermatology department of Rabta, the Rabta Hospital in Tunis again. He's also head of the Leishmaniasis Laboratory, Public Health and Infectious. He's director of WHO Collaborating Center on Management of Cutaneous Leishmaniasis, and expert on Leishmaniasis for WHO. He's a member of many national and international dermatological societies and committees. He reviews many journals, many indexed dermatological journals, and is an associate editor of 3 journals. He has authored more than 250 scientific articles. He has written multiple chapters of textbooks and medical encyclopedias. He's editor of the text Dermatology Infectious at Elsevier Masson in 2014. He's a member of the Dermatology Technical Advisory Group for WHO International Classification of Diseases, as you know, the ICD-11. Member of the Skin NTD subgroup of WHO Diagnostic Technical Advisory Group, and reporting to the Strategic and Technical Advisory Group for NTD, STAG NTD, in September 2020. He is a consultant for WHO on cutaneous leishmaniasis and NOMA disease. He participates in some field missions and co-authoring the WHO guidelines on the management of cutaneous leishmaniasis for the EMRO and Euro regions, and collaborates in the international courses on NTDs. It's a pleasure to invite Dr. Murad for this session, and you can start your presentation. Dr. Murad?
He's not.
Dean?
I don't think he's online.
Dr. Murad, we see your slides. We had a problem?
He's not online.
Oh. Okay, so perhaps until we sort out.
Okay. Okay. So maybe we can move. He has no access on the presentation, or that he is connecting.
Oh, Dr. Murad. Professor Murad.
He's connecting.
Okay, sorry.
Yeah, he's connecting.
Yeah.
Sorry. Are you hearing me?
Yes, we do.
Thank you. Sorry.
So you just connected, right?
No, I connected as participant. Sorry. Okay. Thank you very much. Thank you very much.
Yeah.
Okay. Thank you very much.
Okay.
Thank you. I thank you for. Sorry for the delay. Thank you. I have to thank the organizer of this very interesting meeting, especially Dr. Byron and Dr. Wasuna for their kind invitation. It's a great pleasure to see Dr. Kinyeru Esther and all the chairs and all the participants. But I think Dr. Byron did not offer to me an easy task, because I think it's very difficult to speak about cutaneous leishmaniasis in Africa. And next slide, please. We can identify in Africa 4 sub-region, a class sub-region and country cluster regarding the epidemiology of Leishmaniasis. First of all, North Africa, next slide. East African region, next slide. West African region, next slide. And Southwest African region, next slide. If we see the distribution of CL in Africa, next slide. The epidemiology of Leishmaniasis in North Africa mainly is distributed on 5 countries: Morocco, Algeria, Tunisia, Libya, and Egypt. Next slide. For Morocco, Algeria, Tunisia, and Libya, there is almost the same distribution of the 3 species, Leishmania and phantom in the north coast of this country. Leishmania major, which in extensive area, which is an epidemic and health public problem, and Leishmania tropica mainly in some foci in this region. Next slide. In Egypt, mainly the 2, Leishmania major and tropica, Leishmania major essentially in Sinai Peninsula, with small foci of Leishmania tropica. Next slide. The distribution of these 2 species, next slide, and their reservoir host. Leishmania major, especially MON25, has a high incidence rate in all North African country. It's a zoonotic CL. It's distributed in the arid and Saharan bioclimatic stages. It's in epidemic pattern with seasonal variation. The vector are mainly the Phlebotomus papatazi, and the reservoir is the fat citrand Psammomis obesus and the Gerbils meriones species. Leishmania tropica, it's mainly in Morocco. It's distributed in rural foci and the arid mountains of Morocco. It's in sporadic pattern. It's mainly MON8, which is with especially Leishmania tiliki, it's a variant, and the vector is Phlebotomus sergeanti. In Morocco, it seems to be anthroponitic, but it's not sure. In Tunisia and Libya, mainly the Gondi is the main reservoir of this type of Leishmaniasis. Next slide. Leishmania tropica, phantom, it's in dermotropic strains distributed in the northern part and coast of this different country. It's on sporadic pattern. It's in the visceral Leishmaniasis area. MON25 is the most frequent, and multiple vector, Phlebotomus perfiblevi, perniciosis, noncuspis, and ariazi, and the reservoir is the domestic dog. For the epidemiology of Leishmaniasis in the second cluster of East African country, next slide. We go through rapidly, we go through Ethiopia because Dr. Ndalama will be more specific in this country. Next slide. Next slide, it's the next presentation. Next slide. For Sudan, next slide. Sudan is a highly endemic country for both cutaneous Leishmaniasis and visceral Leishmaniasis. The incidence rate is 0.94 per 10,000 inhabitants. It's found in the central and western states of the country, and CL is caused mainly by Leishmania major, but there is a small report on cutaneous lesion with Leishmania donovani, especially in visceral Leishmaniasis area. The vector is Phlemotomus papatasi, and the reservoir is Arvicanthus niloticus, the Nile rat. Next slide. Kenya, CL is endemic in Kenya. There are lack of accurate data. Leishmania tropica predominantly found centrally in the Rift Valley. Leishmania major reported in the lowlands of Kichu and Baringo, and Leishmania aethiopica detected in area of high altitude like in Ethiopia, such as Mount Elgon. And the vectors are various vectors: Phlevotomus duboski, Phlevotomus kirchbergi, and Phlevotomus pedifer. And the reservoir is mainly the rock Hyrax. The epidemiology of Leishmaniasis in West Africa. Next slide. Next slide. There are high lack of accurate data, but cases of Leishmaniasis have been reported in 10 countries in West Africa, mostly from Mali, Nigeria, Senegal, Cameroon, Burkina Faso, Mauritania, Gambia, Ivory Coast, Guinea, and Ghana. Next slide. Only Leishmania major has been reported from this country, and multiple zymodems, MON 25, MON 26, MON 74, MON 117, and LON 1. The vector is Phlevotomus duboski. And the reservoir are multiple rodents. Next slide. The Ghana has a special situation with a new species, with the Leishmania henrieti complex, with some report who report a new species of Leishmaniasis, Leishmania henrieti complex. Next slide. And finally, the final cluster, it's in Southwest African region. Next slide. Mainly in Namibia. Most of the cases are from Keermanshoop, Karasburg, Bethany region. The species are not very well studied and identified. And the vector old reports, they report Phlevotomus rossi, and the reservoir seems to be the Hyraxis. Next slide. Now, if we summarize according to the parasite, next slide. Leishmania major, it's the high burden of the disease, North Africa, West Africa, East Africa. Next slide. Leishmania infantum, it's mainly the North African country in Fossai, but also in other countries in Eastern Africa, like Ethiopia, like Sudan, and in West Africa also, some countries. Next slide. Leishmania tropica, it's mainly in small, in Fossai, in Morocco, in Egypt, in Kenya, and Ethiopia, and Namibia. Next slide. Leishmania tropica kiliki variant is mainly in North Africa, in Tunisia, Algeria, and Libya, and Ethiopia mainly in Ethiopia and Kenya. Next slide. Leishmania donovani, like Leishmania visceral Leishmania, mainly in in East African countries. Sorry. Next slide. This is the report. This is the map, but we still don't know the reality of the epidemiology of cutaneous leishmaniasis in CL. I can give you 3 personal experience example that we have a lack of accurate, and the burden of CL in Leishmaniasis is higher than we know. In a mission in Kenya, you see with me Dr. Isra Cruz from Spain, and Esther Kinyero from Kenya, and other colleague from DNDi Kenya in July 2016 in Gilgil in Kenya. Next slide. When we was in the hospital in Gilgil, next slide, most of the patients have Leishmania recidivans. And this is a peculiar form of cutaneous leishmaniasis with a high immunity against the parasite, but it's very resistant for the treatment. Next slide. But when we see patient in the field, next slide, almost most of the patient have a classical leishmaniasis. Next slide. That means we are in selection bias situation, and the hospital select the most resistant cases, but the reality, next slide, of the CL in the region is more than the hospital can see, because the hospital can see only the top of iceberg. The main burden of classical leishmaniasis, maybe they don't look for care. Next slide. This is a report of a Kenyan colleague with Esther Kinyero as co-authors. They demonstrate that also Leishmaniasis recidivans it's seen in relatively high level in Kenya. Next slide. Other report from Kenya also. Next slide. The second example is from Cameroon. Next slide. There are reports in 2017, there are report of an epidemic of mysterious disease in children with a high mortality. Next slide. In the extreme north of Cameroon. Next slide. There are around 15 children seen with a high mortality. The symptoms are long-lasting fever, general health impairment, weight loss, polyadenopathy, hepatosplenomegaly, and cutaneous rash. The cutaneous rash don't seems consistent with leishmaniasis. There are violaceous plaque on the skin. Next slide. Violaceous plaque on the palms. Next slide. Violaceous lesion on the palms and soles, and polyadenopathy with a high mortality. This is not consistent with cutaneous leishmaniasis. Next slide. But the Institute Pasteur of Cameroon, they find leishmaniasis, next slide, in this skin lesion. Next slide. They found, next slide, mastigotes in in this lesion, cutaneous mastigotes in the skin lesions, and it was a situation which is not clear. And I went to Cameroon with Dr. Ivan Dario Velez, a great expert on leishmaniasis. Next slide. And we see the same situation. That means children with the violaceous plaque on the extremities. The next slide. In the soles, next slide, the same situation. And nodules, violaceous nodules, next slide. With lymphadenopathy, next slide. And we found also Leishmaniasis on this lesion. Next slide. We found on such lesion. Next slide. And it was a disturbing situation. The clinical diagnosis was Kaposi sarcoma. Next slide. And there is reports on parasitation of Leishmaniasis in Kaposi sarcoma. This is there is some report. That means Leishmaniasis was opportunistic on Kaposi sarcoma lesion. And the third situation is in Ghana. We followed the situation on Volta region in Ghana. Next slide. And Dr. Richard Akufu and his colleague and some colleagues from WHO followed the situation for children with the highly prevalence of leg ulcer. And the first study, the preliminary and first study, showed that the third of this patient have CL and with in this region. Next slide. That means we know some data in Africa, but the road still very long to have a good idea on epidemiology of CL in Leishmaniasis. Thank you very much for your attention, and thank you very much for your invitation.
Mr. Murad, it was a very enlightening talk, and all this information you don't get it by reading, so it's a very important contribution to this session. Thank you very much. We move on to we will accumulate the questions towards the end, and we will proceed with the next presenter, who is Dr. Ndalamau Gadisa from Ethiopia. So Dr. Ndalamau has a base at Arma Hansen Research Institute. He is a lead researcher in malaria and neglect tropical diseases. He had done his first degree, second degree from Addis Ababa University, and a doctoral degree from the Complutense University of Madrid. His main interests are NTD, environment, public health interface. His research has ranged from geospatial, molecular epidemiology, etiology, sociocultural, clinical. He started his career as a forensic biologist at the Ethiopian police up until his current career at AHRI as acting director of the Malaria and NTD Research Directorates. Dr. Ndalamau would be covering the epidemiology of cutaneous leishmaniasis in Ethiopia. Dr. Ndalamau, floor is yours.
Thank you, Prof, and thank you for inviting me for the organizers. And also, I'm very thankful for Professor for walking us through Africa. So he has made my life easier. So I would be focusing only on Ethiopia. So coming back to Ethiopia, cutaneous leishmaniasis is a public health problem. It is not only a problem in the rural areas, it is also has a significant implication even in big cities like in the north, in Gondar, Mekelle, and also even its existence in Addis has been reported. As the previous speaker said, in our situation, the etiologic agent is mainly the Leishmania topica, and the estimated incidence is up to 40,000 cases per year, and it is mainly affecting the young adults and adolescents. Next slide, please. As per the environmental factors, as you see from here, the situation is more of in the highlands, in the eastern and western escarpment of the Rift Valley system. Mainly, these are the rock cliffs in the east and western mountain and plateaus of the central parts of Ethiopia. In terms of population at risk in those areas, over 29 million people live at risk, and the important environmental factor predictive of the existence of cutaneous leishmaniasis in Ethiopia includes the slope, elevation, and annual rainfall. Currently, we are developing a refined risk map. Maybe if you can go to the bottom link and give us inputs, we will be very grateful. We are starting to develop a refined risk map of leishmaniasis in Ethiopia. So for this audience and your colleagues, please go into that link and provide us your inputs. Next slide, please. And when we go back to the history of leishmaniasis in the early 90s and late 90s, there was an intensive epidemiological studies that established the life cycle and epidemiology of leishmaniasis. And until today, so there are some reports from like rodents, even bats. The rock hyrax are the well-known established reservoir host for cutaneous Leishmania atopica. And the sandfly vectors are Phlebotomus longipes and Phlebotomus perifer. And humans are actually incidental hosts as they enter into the natural cycle. Next slide, please. In terms of the clinical manifestation, Leishmania atopica infection could be manifested into 3 major clinical forms, of which the localized cutaneous leishmaniasis is the most common, and it could range from chronic to self-limiting benign type of non-ulcerative or ulcerative lesions. In both cases, this kind, the localized cutaneous leishmaniasis, could lead to a lifelong aesthetic damage. Next slide, please. And the other clinical manifestation due to Leishmania atopica infection, which is relatively rare, is the diffused form of cutaneous leishmaniasis. And this is non-ulcerative, covering the whole body, but it is very difficult to cure and even life-threatening. In terms of epidemiology and etiology, the previous studies have established that this form of cutaneous leishmaniasis is actually distributed in almost all endemic sites of Leishmania atopica, meaning at least in terms of epidemiology and ecology, there is no difference in terms of the variation in this clinical form. Next slide, please. And the other important clinical manifestation in Ethiopian Leishmania atopica infection is a mucocutaneous form, which is life-threatening and mutilating and very damaging type of cutaneous leishmaniasis, which is relatively common. And Ethiopia is among the top most affected by this kind of cutaneous leishmaniasis. Next slide, please. And the prevalence of this mucosal and mucocutaneous form of leishmaniasis, although there are few reports, the prevalence could range from 19 to about 22% in different settings, including community-based studies and hospital-based studies. though the number of studies and participants are very few, the burden is really high. Next slide, please. In terms of the trend of cutaneous leishmaniasis in Ethiopia, I have tried to see some few treatment centers, like where Aris is now is Alert Hospital. If you see, the trend is like it is increasing from year to year. And also, if you move to the next slide, please. And in the north, in Gondar Hospital, if you see, there is as such no change in the treatment seeking behavior is increasing, and the number of test positive leishmaniasis cases is coming continuously without change the previous years. Next slide, please. If we also move to the northeast, the Borumeda Treatment Center, the number of cases in that specific setting is really increasing. And that means then in our situation, there is no tendency that there is something being done to curb the transmission of cutaneous leishmaniasis. And there is as such no intervention that is reducing the burden. And a lot remains to be done in terms of patient treatment and management. Next slide, please. So the challenges in our setting could be also due to the uniqueness of the epidemiology. We have almost one species causing cutaneous leishmaniasis, for which the epidemiology, the diagnosis is really poorly known. There are almost no randomized clinical trials in looking into the diagnosis, treatment, prevention, and controls. There are very few or almost none operational researches that looked into the prevention control, and that would help the program and community level prevention and controls. There is no any indication in the improvement of patient care, and healthcare provisions is at this rudimentary situation. So a lot remains to be done in terms of cutaneous leishmaniasis in Ethiopia. I acknowledge my institute and the Ministry of Health in this effort to present this, and DNDi for inviting me to present this. Thank you so much.
Thank you very much, Dr. Ndalamau. Yeah, we still have two more presenters, so I would refer the next presentations to Dr. Esther. Dr. Esther, please lead the next sessions.
Thank you very much, Professor Asrat. We're glad to continue in this session on CL advances. To our audiences, we are receiving questions from our Q&A function on chat. And we continue the hashtag Leishmaniasis, hashtag Africadaya, hashtag Beat NTBs. So after hearing from Africa and specifically Ethiopia, we are going to cross a bit to Asia, where we will receive the Asian perspective on the same from Nadra, who is the chair and senior professor of parasitology at the Faculty of Medicine, University of Colombo, and an honorary visiting fellow, Harvard University, USA. She has made pioneering contributions to the field of leishmaniasis in Sri Lanka. She is the first Sri Lankan elected as an honorary member of the American Academy of Arts and Sciences, and as an international fellow of the American Society of Tropical Medicine and Hygiene. She's an elected fellow of the World Academy of Sciences and the National Academy of Sciences of Sri Lanka. She's the founder president of Sri Lanka National Chapter of Organization for Women in Science for the Developing World that champions local young scientists, and especially women. It's my pleasure to invite Nadra to take us through cutaneous leishmaniasis, Asian perspective, and the effects on the quality of life. Welcome.
Thank you, Esther. Am I being heard?
Yes, you are.
Okay, thank you. Let me focus on cutaneous leishmaniasis. And to give you a broad background very briefly, it is a disease that has spread across the world, and Asia is no exception. It's across all continents. And the figure on the left side of the screen will show the distribution, and on the right side is just to show where Sri Lanka is located in the map. It is an island which is located close to India. And as you can see, the burden of cutaneous leishmaniasis is fairly noticeable there in the world map that is on the left-hand side. Next slide, please. Cutaneous leishmaniasis is endemic in Sri Lanka, and we have other clinical forms like visceral and mucosal type of leishmaniasis as well, but in very few numbers. So the predominant clinical form that we see is cutaneous disease, and these patients present with lesions that are shown at the bottom, very tiny papules, nodules, or ulcers, as you can see at with the figures at the bottom. And these are classically non-itchy or non-tender, and they are found on exposed areas of the skin where it is exposed to sandfly bites. So you get the lesion at the site of the sandfly bite. So unless they are associated with secondary infections, these classical features prevail. The causative agent is Leishmania donovani MON37. And as you can see on the right-hand side, it is a very enlarged image of Leishmania amastigotes GM stained smear. Inside macrophages, the amastigotes can be seen beautifully. And the vector in Sri Lanka, the incriminated vector is Phlebitomys argentipes, that you can see again an enlarged view on the right-hand side of the screen. The first local case of cutaneous leishmaniasis was reported in 1992. However, things were fairly quiet until 2001, when we detected this outbreak. As you can see in this trend graph that is at the left-hand side bottom, the leishmaniasis case numbers gradually increased. However, during the past couple of years or so, there was a drastic increase in numbers. So now we see over 4,000 cases of cutaneous leishmaniasis annually. And on the right-hand side of the screen, you can see the spread or the distribution with the burden. As you can see, it's not a uniform distribution across the country. However, all districts are affected. There have been cases reported from all districts, with north central and the southern parts of the country being affected most. Next slide, please. Right, this is just to show how it has progressed from 2001 onwards. As you can see at the top row, it goes in 3 rows up to 2018. It shows how the burden of disease has increased, as well as the spread of disease across all districts, while ending up with the north central and the southern parts of the country being affected most with the highest burden. Next slide, please. As we all may have heard, cutaneous leishmaniasis is considered as a self-limiting condition, but the disease burden is mostly due to the painful, repetitive, and prolonged nature of the treatment that is in Sri Lanka. we use sodium stibogluconate intralesional injections. You can see an image of a child being injected intralesionally. So it's not a very pleasant form of treatment, and this needs to be repeated at weekly intervals for several weeks or months. There are minimal side effects because it's given intralesionally. However, the major problem that we see is the poor response to treatment, with the recent reports indicating over 75% of cases not responding to intralesional sodium stibogluconate. So we have tried alternative local treatment in the form of radiofrequency heat therapy. We did a clinical trial which was very successful. However, due to time constraints, I'm not going to describe this. I'm sure this might come up in the next presentation by Byron. So the issue is the long-term persistence of these wounds, which leads to scarring, not to mention the increased risk of spread. Which is of public health concern. Secondary infections of lesions also leads to complications because they last for a long time, and the financial burden associated with this disease can be considerable on the patient as well as the family. So very broadly, the impact of cutaneous leishmaniasis can be categorized into psychosocial and financial impact, which contributes to the effects on quality of life of these patients and their families. Next slide, please. I'll start with the economic consequences of cutaneous leishmaniasis in Sri Lanka. And the patients are actually treated in the government health sector almost exclusively, because the private sector does not have access to this treatment, sodium stibogluconate. So the patients are referred to the government hospitals, and the treatment is offered free of charge to patients. However, the economic impact on patients and families is due to the regular travel that is required to access treatment, with some patients having to travel long distances to access treatment. And this needs to be done regularly at weekly intervals for several weeks, which adds to the burden. So there's travel cost involved, as well as loss of working hours whenever they are asked to come. So there have been only a few past studies that have assessed the quality of life of these patients. So I will try to summarize a couple. There was a hospital-based study that we conducted in 2018, which looked at level of impact on these patients, the quality of life. And the study was done through the use of a dermatology life quality index questionnaire, and nearly 300 patients were included in this hospital-based study. The main findings were there was a considerable large impact of the disease on quality of life in about 10.6% of patients. The impact was more in the case of ulcers, plaques, and nodular ulcers when compared to nodules or papules alone. The second study was done a few years earlier in 2014, again using this DLQI or Dermatology Life Quality Index questionnaire. And that revealed that young adult males between 21 to 40 years with bigger lesions of more than 2.5 centimeters, which were located on their faces with more than 6 months of duration, were more affected when compared to other groups. So the extent of impact of quality of life in these cutaneous leishmaniasis patients tended to depend on the nature of the lesion, size, and duration of the lesion. And on the part of the patient, the age, gender, and occupation of the patient also seem to influence the level of impact. I thought I will take an ongoing qualitative study and also a case study that we conducted as examples to elaborate on these generic points that came out of the earlier publications on quality of life due to cutaneous leishmaniasis. The ongoing study is a part of this project called Eclipse. It has a long name, Empowering People with Cutaneous Leishmaniasis, intervention program to improve patient journey and reduce stigma via community education. It involves ethnographic field study, and the main center is based at Rajarata University, that is in Anuradhapura district, that is in the north central part of the country where the study sites are located. You can see the study, the PI is Sunita Gampadi, and I am a co-investigator of this study as well. If we can go to the next line. Yes, so ethnographic approach is used and it involves participant observation, interviews of these selected individuals, as well as a diary study. And the stars, the red stars shows the field sites in Padaviya, Nachaduwa and Talawa that all are within the Anuradhapura district, that is in the north central province, where there's a lot of burden of leishmaniasis. So the observations were recorded at interviews, and I selected a few that I thought would be of interest to this audience. One is the monk of a village had a lesion on his face. You can't even look at him. It's an abomination. The second comment that I would like to share, if you can go to the next line. Some people came to the clinic, had lesions on their faces, noses and eyelids. You can't even look at them. I was so disgusted. So this was another observation that was recorded at interviews. And the picture shows Hasara, who is the research assistant involved in this study, and the field work, the team is shown in other pictures as well on the right side of the screen. Next slide, please. This is another observation. There was a patient in clinic with a boil on his nose. His nose has no shape. I initially thought he has placed a frog on his face. I thought to myself, why on earth this man has placed a frog on his face? His whole face is distorted. I hope he won't lose his nose. There's no point in living without a nose. So this was another notable observation. Next slide, please. So there were interesting observations from diary studies as well. So this is the type of booklet that is given to these participants from the study sites. If you can go to the next line, yes. This is some selected observations that have been recorded in these diaries. What I understand is that although I am not too bothered by this disease, a lot of other people are severely bothered by the disease. Next line, please. The people of that village are afraid of this disease. The uncle said that he feels villagers are marginalizing him, treating him differently because of this disease. Then another observation. It is not uncommon for some young people to be subjected to ridicule from society. That was another diary entry. Even though they are at an age where they love being pretty, the sandfly has done a serious damage to their beauty. I pitied them. So that was yet another recording. So I think that gives you broadly an idea of the type of feelings and the quality of life of these patients in this that came out through this ongoing study. And then I would like to share this case study from Bhutan. Again, we are involved in this. This is a study site that we are involved in as part of the NIH project that I lead. And this is a 37-year-old female, a mother of 3 children from the eastern part of the country, Bhutan. And the patient was seen by a dermatologist in 2014 with a past history of visceral leishmaniasis 15 years back. and the patient presented to the dermatologist. If we can go to the next, the image, yes. A patient presented like that with extensive erythematous plaques on affecting the entire face. The left eye was totally damaged, and there was marked swelling seen on the right eyelid as well. So there were plaques extending across the face, involving the entire face. Next line. The skin biopsy was done, and there were Leishman bodies seen. So the patient was diagnosed as post-kala-azar dermal leishmaniasis and treated with intramuscular injection of sodium stibogluconate that was given for nearly 1 month, and the lesions resolved. However, it was temporary because it came back in 3 years later. And again, a biopsy showed positive. If we can see the image, yes, that was the recurrence. And then the next line, please. Next line, yeah. The patient was treated successfully with liposomal amphotericin B, which was again given for nearly 1 month. So it resolved, and if we can go to the next slide, you can see the image, how the patient appeared after recovery. So this was a case of PKDL, or post-kala-azar dermal leishmaniasis, and it is obviously a chronic debilitating form of disease, and the entire episode lasting over 2 decades, and it has had devastating impact on her with severe facial scarring, loss of one eye, and also severe mental distress. And effects on the patient and the entire family in terms of economic burden has been considerable. The family is said to be in heavy debt, and the social stigmatization and isolation has been considerable. They are not even able to go to the temple to move with the other people. If anyone is interested, the case report will provide more details. It was published in 2020. Next slide, please. Yes, so in summary, it could be said that although cutaneous leishmaniasis is generally considered as a self-limiting condition, the psychosocial impact on the patient and the family seems to be considerable, with economic consequences as well, particularly on the poor. Effects upon quality of life may significantly vary between patients and may depend on the nature, size, and duration of the lesion, and on age, gender, and occupation of the patient. Overall, early diagnosis and effective treatment is recommended to avoid the physical as well as psychosocial ill effects of this condition, and also to minimize the spread of disease in the community. So it's of public health importance. Thank you.
Thank you so much, Nadra, and especially now for bringing out the psychosocial effects of CL, which is at times ignored, and the disfiguring effects and the stigma and the effect on self-esteem. Thank you so much for that session. Luckily, different players and partners are putting in effort on CL to allay some of these effects and to help the patients, which brings us to our next presentation to see what DNDi, the efforts they are putting in the CL management. We are privileged to be joined by Dr. Byron, who received his medical training at the University of San Carlos at Guatemala, and his doctoral degree on tropical medicine from the University of Liverpool, UK. Since 2013, he has been serving as the head of cutaneous leishmaniasis disease at the DNDi based in Geneva. Before then, he was in charge of managing clinical trials on visceral leishmaniasis at TDR-WHO, that TDR-WHO was supporting in the Indian subcontinent and participating in the development and implementation of strategies in support of the Indian subcontinent visceral Leishmaniasis. So to sum up this session on oral presentations on CL advances, it's my pleasure to welcome Dr. Byron to take us through his presentation. Welcome.
Thank you very much, Madam Chair. It's a pleasure to be here. And also, I believe it's a very nice opportunity because I'm sure the majority of the people attending these meetings are quite familiar with the efforts that DNDi is conducting in Africa, but especially on visceral Leishmaniasis. For cutaneous Leishmaniasis, there is not much that we are doing so far in that part of the world. So I believe this is a very nice opportunity to socialize what we are doing as part of the DNDi efforts on cutaneous Leishmaniasis, because we cover not only visceral Leishmaniasis, but cutaneous Leishmaniasis as well. So as just briefly, as you all know, cutaneous Leishmaniasis is endemic in 88 countries. It has been estimated that between 0.7 to 1.2 million of new cases occurs worldwide, which means that almost every 30 seconds we have a new case of cutaneous Leishmaniasis. Eastern Mediterranean region contribute to nearly 60% of the global CL burden worldwide. There are several species of vectors and reservoirs involved. There are no vaccines, no chemoprophylaxis, and the drugs that we are currently using for the treatment are very scarce. Just few of them are really available. Current treatment recommendations are basically based on the clinical presentation of the disease and the species of Leishmania causing the disease. And those recommendations go from no treatment for those lesions which are small in size and number, especially those which are considered to be self-limited diseases like lesions due to Leishmania mayor or mexicana. And then for local therapies for what we call uncomplicated cases of cutaneous Leishmaniasis, which means patients with less than 4 lesions in size and in number, not located in face or in other areas of the body, which the application of a topical treatment is difficult. And then we have a systemic treatment, which currently is miltefosine, the only oral drug available, but not used for cutaneous Leishmaniasis as widely as for visceral Leishmaniasis. Even though it received the FDA label to be used for cutaneous Leishmaniasis as well, there are very few countries where they are using it on routine basis. So the most frequent drug used for the treatment of cutaneous Leishmaniasis antimonials, either sodium methylgluconate or meglumine antimonials. And of course, we have some combinations. It has been mentioned before that some form of Leishmaniasis, like Leishmania recidivans, is very difficult to treat. Mucocutaneous Leishmaniasis is, of course, very difficult to treat. And then there are those patients who have very aggressive and very extensive lesions where the antiparasitic drug doesn't work very well alone, and then it's given in combination. Next. So what we are using, as I said before, is antimonials, and we all know that this is a very old drug with a lot of problems, causing a lot of cardiac effects, hepatic and renal side effects. And it requires daily injections, which is painful and difficult to administrate. Next. And next. So there is a need to really develop topical and oral new treatments, which are safer than the one we are using now, hopefully at lower cost, and against all forms of cutaneous Leishmaniasis, and especially those which are adapted to be used in the rural areas, because injections, as it was mentioned by Professor Nadira, a lot of the costs associated with the treatment are on the patient side because they need to come to the clinic every day for the injections. But there is not only the disease itself, it also brings another sort of problems, mental health problems associated with the disease, as mentioned by Nadira in the previous presentation, and that even though it affects men and women in general, it has been very well determined that women and children are the more affected, and they carried a lot of the burden in terms of stigma and mental health problems associated with the disease. Next. So we believe that there is a lot of improvement in terms of the treatment. So there is, for example, a room to improve in efficacy. Current drugs barely reach between 50 to 70% cure rate in all forms of cutaneous leishmaniasis. The adverse events associated with the use of the current treatments are very high. Miltefosine, even when it's an oral drug, there is a high proportion of patients reporting gastrointestinal problems, for example, and a few of them also report renal problems associated with the miltefosine. And antimonials, as you know, have a lot of problems with cardiac effects and renal and hepatic problems as well. The length of the treatment is also, some cases of patients coming for intralesional treatment, for example, comes up to 17 weeks to receive injections on a weekly basis. And that is a long period of time, which of course impact in the adherence of the patients to the treatment. Deletion takes also, we can expect previous. We can also aim to improve the speed of healing, because sometimes deletion takes a lot of days or weeks to heal. And finally, something that I already mentioned is compliance to the treatment. So it has been demonstrated that those patients who are subject to be treated with, for example, with intralesional antimonials for 10 weeks, less than half of them complete the treatment. And even patients receiving intramuscular injections, not all of them complete the 20 days or 28 days treatment because the side effects associated. Next. So DNDi strategy aims to bring new treatments which are safer, non-invasive, efficacious, and affordable, and hopefully to be friendly used in the field. Next, we have two different approaches. One is looking at the long term, which is activity that we know are going to take several years to be completed. And in this context, we are basically focusing in oral drugs, in developing oral drugs, and developing an immunomodulator for the treatment of cutaneous leishmaniasis. We are also supporting the efforts of topical treatments. For those are not led by DNDi, we are just supporting other groups who are engaged in this activity. And the reason behind this is also because we don't want to duplicate efforts, and there are several groups already working on topical treatments. Next. In the short period of time, we believe that there is still a room to improve using the current recommended treatments when used in combination. So the same way that DNDi has conducted several studies using combinations in Africa for visceral leishmaniasis, for example, paramomycin plus miltefosine. For cutaneous leishmaniasis, we are also looking for options to use in combination the approved and existing tools. Next. So for each of these activities, we have different projects, which I'm going to describe in the following slides. So I'm not going to spend more time here in this slide. Next. Starting with the use of combinations of the current existing therapies. What we are testing is the combination of thermotherapy, which, as you probably know, this is an intervention that has been approved by WHO and is included in the treatment guidelines. The device that we are proposing to use has received the FDA approval for the treatment of cutaneous leishmaniasis and many other dermatological conditions. And miltefosine, as I mentioned before, has also been approved for the treatment of cutaneous leishmaniasis. But sadly, in the studies done before, it has been shown that the efficacy of those interventions when given alone is low, some cases between 50 to 60 or 70%. So we believe that there is an opportunity to improve the efficacy and hopefully go beyond 80 or 90% when combining these two approaches. Next. So what we conducted in previous year a phase 2 study comparing thermotherapy alone and the combination of thermotherapy plus miltefosine. And we found that the combination of thermotherapy plus miltefosine is superior to thermotherapy alone. That was a phase 2 study. Now we are in a phase 3 study where we are conducting a randomized open-label multi-center study looking at the non-inferiority of this combination approach when compared to the standard treatments. The study is being done in 5 sites in 4 countries in Latin America: Brazil, Bolivia, Panama, and Peru. It has 3 arms: the thermotherapy, the combination group, which is, as I said, the use of thermotherapy. This is 50 Celsius degrees for 30 seconds, 1 single application, plus miltefosine at the standard dose of 2.5 mg per kilo for 21 days. It's not 28 as the regular recommended treatment for cutaneous leishmaniasis, but it's only 3 weeks. And the comparative arm are the meglumine and timoniate at the standard dose and miltefosine at the standard doses as well. So this study has already started. The 4 sites are already enrolling patients, and we expect to have the last patient, last visit by the end of next year. Of course, as many of the other projects during this period, we have been suffering some delays due to the COVID situation. On the other side of the slide, you can see what we are using, the standard primary endpoints, basically initial cure at day 90, and the cure is expressed as the 100% reepithelialization of the lesions on day 90. Next slide, please. So regarding the oral drugs, next slide, please. As you perfectly know or have here, DNDi has invested a lot of energy and time and resources in looking for new treatments, new chemical entities for developing new drugs for visceral leishmaniasis. And right now, many of these compounds are already in the clinical phase. As you can see here in this list, there are several compounds with different mechanisms of action that are already in phase 1, and there is one which is ready to enter in phase 2 by mid 2022. Even though all these drugs were initially developed for visceral leishmaniasis, we are lucky because all of these compounds have shown to be also very active against a species of Leishmania causing cutaneous leishmaniasis. So in the following slides, I'm just going to show you very quick examples of the studies done by on cutaneous testing these drugs on cutaneous leishmaniasis model. Next slide, please. So this is the LXC408. This is a compound which is being developed by Novartis, and DNDi will be conducting the phase 2 study for visceral leishmaniasis in next year. But this is just to show that in the biopsy model, here this compound showed to be also very active against cutaneous leishmaniasis. You can see that at the 1 mg per kilo for 10 days, it was also as good as Ambison. Sorry, 10 mg, 20 mg. 20 mg for 10 days was as good as Ambison. The 2 lines at the bottom of the diagram. Next. So this is the other compound. This is one of the nitroimidazoles, the DNDi 0690, and this is also in the mouse model for CL. These are lesions due to Leishmania mexicana, and also as you can see in the line in yellow, this is very effective in reducing the size of the lesion as compared to the Ambison, and of course as compared to the control group, which is the blue line, and is as you can see by day 10, by day 11, the size of the lesion in the control group is very high as compared to the yellow one, which is the group receiving the DNDi 0690. Next slide. One last example is the Oxabarol 6148, and this is also showing the results of in 2 different models, in the foot pad and on the rump model. And here we are comparing with Ambison. And again, the efficacy measured in terms of the reduction of the lesion size along the days after the treatment, it showed that these drugs are very, very effective also against strains causing cutaneous leishmaniasis. So in the following slide, I'm going to show you what we are doing with this slide. One of the compound which is being specifically developed for cutaneous leishmaniasis right now is an immunomodulator. As you all know, the immune response from the host is key when determining the outcome of the disease. So we believe that there are some patients who might benefit of receiving an immunomodulator because the antiparasitic drug is not good enough to control the infection. So in this sense, we are using a TLR9 agonist called CpG ODND35. This CpG was patented by FDA, and DNDi received a license to continue the work for cutaneous leishmaniasis in 2009. It is a class A, also known as class D oligo. Is basically designed to activate the innate immune system and enhance the effector mechanism to control Leishmania infection. It has been tested in monkeys for the CL major infected with the major and L major and Amazonensis with very encouraging results in terms of reduction of the pathogenicity and enhanced healing even when administered alone. We have been able to complete the preclinical studies in 2020, and now we are conducting the single ascending dose studies in healthy volunteers in UK, and we are close to complete this study. And after that, we are planning to conduct the multiple ascending dose studies in CL patients. So we believe that so far this is a very encouraging result of what we are observing in the SAD study, and we will have results of this study by the end of this year. And hopefully by 2022, we will be able to start the multiple ascending dose of this CpG given in combination with an antiparasitic drug for patients with CL. Next. So, but there are other activities where we are also involved. Regarding the new chemical entities, as I said, they have been shown to be active against cutaneous leishmaniasis strains, but more studies are needed. During the next 2 years, we will be involved in conducting more detailed PK/PD studies to analyze how these drugs behave in the skin, and basically looking with more detail how these drugs will interact and will concentrate and will interact with the parasite in the skin. This is a project that has started just a couple of months ago and will last for 2 more years. And several institutions, including the University of York, Netherlands Cancer Institute, and Imobiatech, and the University Federal of Rio de Janeiro are involved in this effort. We are also working in efforts to replacing antimonials for the treatment of uncomplicated cutaneous leishmaniasis. We have several activities ongoing. One is in Ethiopia, where in the context of the EDCTP Leish Access Project, we will be conducting a study looking at the feasibility of using thermotherapy for the treatment of uncomplicated CL cases under routine conditions. But we are also have other operational studies to test the feasibility of launching thermotherapy, and those studies are being efforts are being done in Sri Lanka with the support from Nadira in this particular case. But we are also supporting the Pan American Health Organization in Latin America to conduct similar studies in 4 countries in Latin America. Efforts are also on the same direction, trying to promote to bring a new source of miltefosine, hopefully less costly than what is currently available through the NITE, which is the only manufacturer available right now. And similar, we are doing the same efforts, trying to bring similar thermotherapy machines at a lower cost. Just to finalize, just to mention that one of the big problems in clinical trials looking at cutaneous leishmaniasis is that there is no consensus when using which criteria to evaluate the endpoints, to define cure, when to start counting. And DNDi has been participating in efforts trying to harmonize the way of conducting clinical trials. So below there are several points showing you all the effort that we are doing. Enough to say that so far we believe we have been able to tackle this problem from different angles, bringing new criteria to identify to assess a cure, bringing also the ideas from the patients, what is important from the patient perspective, and also trying to look at how patients in the special population, those who are not routinely treated or included in clinical trials, how they are responding to the standard treatments. So as you can see, our portfolio, our activities in DNDi, in the CL program are very, we're tackling it from different angles. And we are happy that to have this opportunity to socialize all this information in this LEAP conference. Thank you very much. Next, and I think just to finalize, so we are quite confident that in the near future we will be able to replace the current drugs that we are using, mainly antimonials, with something newer, hopefully oral, which we are expecting to be safer and less efficacious than the antimonials that we are currently using. Thank you very much.
Thank you very much, Dr. Byron. Quite some advances and strategies to improve the overall outcome of CL patients. And I'm sure everyone in the CL field who has dealt with the CL patients, if we can get something that is not that painful, away from the enduring painful injections. Once you have that, I think the war against CL would be halfway done. So we are glad for that session. Back to Professor Asrat to lead in the Q&A session.
Dr. Esther, thank you very much. And also the presenters. So we will have this short Q&A session. We have a few questions, and I also have a question. So if I may start with one question from Dr. Abate, and this is addressed to Dr. Ndalamau, in case you have seen the Q&A. Otherwise, he's asking, what is the reason for the abrupt rise in the number of CL cases in the health facilities? Is it because of the increased, the increased, it's about access there, you have better access now that you have more CL cases, or is there any other reason? I think that's, if I can paraphrase it. Dr. Ndalamau. Are you around, Dr. Ndalamau? Dr. Ndalamau, okay. Well, until we sort out where Ndalamau is, let's go for the next questions. If I may ask, I have one question for Byron. It's, Byron, part of the problem with the treatments in CL is I think about formulation. For example, if you, Ethiopica, it is difficult to treat. And when we test the available anti-leishmanials in vitro, they do work very well. The parasite is quite sensitive. So the problem is not really about finding an active anti-leishmanial agent. It's probably relates to tissue distribution. And so wouldn't it be wise to have a targeted investment to have really treatments that can be delivered in the skin or perhaps directly into the lesion, in a single dose or so? If you have, for example, adjuvants and a slow release formulation directly into the skin lesions, wouldn't that help? This is one question. And the other question for you, addressed from Dr. Tamrat, is he was interested to know if you have, why are you testing only on Leishmania major, I think? Would you not test other species? That's his question. So you can deal with those two questions first, and then we will go to the next set of questions. Dr. Byron.
Sure. Thank you, Professor Asrat. In fact, you are absolutely right. But the problem is much more basic. And it comes with the idea that current animal models to test any drugs for cutaneous leishmaniasis are quite imperfect, which, by the way, is related to the second question. You know that it's quite challenging, that quite difficult to develop animal model for Leishmania brasiliensis, for example, or even for Leishmania tropica. And that's why what you are saying is, yes, everything works very nicely in the animal model or in vitro, but when you translate those findings to humans, there is a huge gap. And that's because, in fact, what we observe in the animal model is not exactly replicable to the human host. So related to this, that's the reason we are in the, as I mentioned in one of my last slides, during the next 2 years, we will be engaged in basically looking at the way of developing better animal models for testing these oral drugs that have been, or new chemical compounds that have been identified to be active in the L. Mayor animal model. Trying to better understand how they accumulate in the skin, trying to see how they interact in the skin layers, if they accumulate, first of all, in the skin layers, because reaching very good concentrators in blood is relatively easy, but how these drugs then accumulate and concentrate in the skin is another task. And that's exactly what we will be doing in the following years. Regarding the low release and other kind of formulations for topical delivery, I think this is some activity that the groups working on topical treatments are developing, and we are closely following all of them. Regarding the second question, why only L. Mayor? Well, most of these studies have been done in L. Mayor only because, as I said, so far is the easiest animal model to be used. But in fact, the idea in the following 2 years is to expand this test to other species of Leishmania as much as possible. So we are not limiting and Alabao, I think you are on. You need to.
It's fine. Yeah.
Someone else. Anyway, just to finish that, yes, we will be conducting additional studies during the following years because we understand that the complexity between, let's say, Tropica or Ethiopica and Mayor in terms of treating patients is quite difficult and different.
Okay, thank you. We can close with you, but we'll take one more question. And this question is about the feasibility of the thermal therapy for uncomplicated CL. So this question has been forwarded in the meantime. So deal with this, and then we move on to the next speakers.
Yes, I think it's Dr. Abate who is asking for when we will planning to start. Yes, we are working with Ari and Ndalamao mainly on this. According to the timelines that we submitted to EDCTP, the idea is to have a first patient, first visit by June 2022. We are right now in the process of finalizing all the documents and submitting the protocols and other documents to the regulatory authorities for approval.
He was asking about feasibility. So what does that mean to you? I mean, I don't know exactly what it means, but.
Well, no, that's the title of the study. the title of the study is the feasibility of using thermotherapy in the field under routine conditions. And then, as I said, we are now moving ahead with getting all the approvals, and we are hoping to initiate the study enrolling the first patient by June 2022.
Okay, thank you very much. Please respond to the other questions to, you know, but through the Q&A. And so we have, I have a question for Professor Karunawira. And if I understand, VL is not much in Sri Lanka, right?
Yes, you are correct.
Okay. So it is Donovan and it's phlebotomous adjunctives, and it is MON37. So it's really surprising that not much VL is there in Sri Lanka, and we know that MON37 is causing VL in India, in Kenya, and in Ethiopia.
Correct.
And in southern Ethiopia, for example, we don't have really CL in the VL endemic areas, but the predominant zymodium is MON37. So is there anything related to the host factor, or have you explored into this issue?
Actually, we have looked at it because it's a very important question. We have looked at it from different angles. For example, we have tried to see whether the visceralizing potential of the Leishmania donovani MON37 in Sri Lanka is different from L. donovani, say in India, which causes visceralizing disease. And what we found using in vitro and as well as ex vivo studies, it seems that the ability to visceralize is still there in the local parasite. However, the virulence level seems to be less than the visceralizing parasite for some reason. So it seems to be an attenuated form of the parasites that is causing visceralizing disease elsewhere. This was shown both using animal models as well as in vitro studies. So it seems to be an attenuated form of the parasite for some reason. So, that is the best possible explanation that we can find. Probably not, it's unlikely to be a host factor. We are not really sure. However, it's more likely to be a parasite factor and maybe a combination as well. However, we have found that if the parasites do break through the skin barrier, they can visceralize. So the local immune response seems to be very important in containing the disease, which is interesting as well.
Yeah, very interesting. I think it's more to learn about this observation. Thank you very much.
Thank you.
Yes, thank you very much.
Thanks.
Yeah, and perhaps for Professor Murad, why is the same species behaving differently in different? For example, Tropica is zoonotic in some places. It's anthroponotic. It causes localized lesions. It also causes recidiva type lesions. So you have it in Eastern Africa. It is zoonotic in Eastern Africa. It's rare though, but you have it. But in North Africa, again, it's anthroponotic. So why is this complexity in the same species? Yes, thank you.
Thank you very much. But it's it's very, very difficult question for me. I think in Leishmaniasis, it's a complex process, and it's a balance and between the immunity of patient, the behavior of the vector, and the reservoir. I think it's very complex situation, and in my opinion, nobody knows why this difference in behavior of the vector and the problem of the reservoir.
Okay, thanks.
That means I have no good response for you. Sorry.
Okay, It's okay. Thank you very much. I think perhaps Dr. Ndalema, you could quickly respond to the issue. If I guess we saw you a moment ago. Are you here, Dr. Ndalema? If not, then okay, fine. Is there any other question?
Sorry. I have allow me to have comments.
Yes, please.
Really, I want to thank Byron and DNDi for because they are leading CL. The treatment of CL is very neglected, and they are fighting and giving a huge effort and on this disease. Thank you very much.
Thank you very much. I think Ndalema can respond to the question from Dr. Abata. Dr. Esther, would you like to summarize this or and move on to the next session?
Well, maybe I want to comment, and also I had a few concerns, maybe about the CLBL co-endemicity in Africa. Maybe I don't know if Professor Morad can comment on that, and especially on the guideline, on the development of diagnosis and treatment guidelines, which are will be underway in a few months. Professor Morad.
Professor Morad?
Yes, yeah. I didn't hear very well your question, Esther. Sorry, can you repeat the question?
Maybe you can comment on the endemicity of VL and CL in Africa, and especially in Kenya, and maybe the general guideline on the approach on diagnosis and treatment on the same.
Yes, I think for the situation in Kenya, I think it's a complex situation because we are lacking many data. We are seeing that recidivance it's a problem in Kenya, and this type of CL is very, very hard to treat. And we have no very good treatment for this form. That means the guideline will be as the others guideline at the EMRU, but we have to emphasize on special management for recidivance.
Thanks to our presenters.
Dr. Esther.
Sincere thanks to our presenters. The presentations were quite rich. Hearing the latest in CL. So I think it's a great opportunity to go to our presentation. So I think it's a good chance to go to our poster presentation. I would start us off with Alice. She's a master's degree graduate of immunology and clinical microbiology at the College of Health Sciences, Makerere University. She's currently a flow cytometer manager working in the immunology lab and PhD student in the Department of Immunology and Molecular Biology, Makerere University, under the ADCTP PKDL project that is focusing on the immune status of VL patients before and after treatment. Currently interested in understanding the role of B cells in Leishmania donovani infection. Welcome, Alice, as you take us through that poster presentation.
All right, thank you very much, Dr. Esther. Well, my name is Alice Bayana. here to present my poster entitled Building Capacity for Flow Cytometry in the Leishmaniasis East African Platform in Uganda. Well, the burden of neglected tropical diseases still pose a challenge to optimal healthcare, and specifically visceral leishmaniasis accounts for 2 million annual incident cases with a 95% case fatality if left untreated. The diagnostic methods available are limited, have limitations, especially with providing the immunological picture of the parameters that are affected during disease. And understanding these immunological parameters is important in improving the diagnostic capacity. And with the recent advancements in immunology research, there is need to strengthen the capacity for the use of flow cytometers, especially in Uganda, focusing on leishmaniasis research. And through the PrevPKDL project, we acquired a Cytoflex LX flow cytometer. This is a 19-color state-of-the-art, user-friendly, high-resolution machine that has supported a number of students from undergraduate to postgraduate students here at Makerere University. And this machine has proven it has formed a foundation for strengthening the capacity for the use of flow cytometers at the university, and specifically in the Department of Immunology and Molecular Biology at Makerere University. So this is the machine under the method section, and some of the work that we have done where we immunophenotyped splenocytes, basically looking at the lymphocyte and monocyte subsets, under which we went ahead to look out for the CD4 and CD8 T cells in the lymphocyte populations. We managed to look out for markers of immune activation, cytokine markers, exhaustion, among others. This is just a brief picture summarizing some of the work that we've been able to do with the one machine that we acquired under the PrevPKDL project. And in conclusion, the objective of expanding capacity for flow cytometry feeds into the LEAP purposes for strengthening clinical research, especially in the impoverished regions where leishmaniasis patients are found. And this is possible through acquisition of more equipment to enable resource sharing, collaborations, webinars, and hands-on trainings for researchers at Makerere University. I'd like to acknowledge my supervisors, Professor Joseph Olobo and Dr. James Sande. I'd like to acknowledge the LEAP platform, Africadia, DNDi, and the PrevPKDL project for supporting me. Thank you very much.
Thank you very much, Alice, for the precise poster presentation. In consultation with Professor Asrash, do you have all the presentations? Then we comment later.
Okay, I think the presentations will have to be 3 minutes. I don't mean that Alice has bypassed that, but just a reminder. And so if there are questions in the Q&A, we have to use 2 minutes for Q&A. And I think there is a question.
No.
No? Any question for Alice? Professor Olobo, will you have a comment?
No comment.
No comment.
Well presented.
That's well presented. Okay, Alice, you're involved in training others too. Your center is now a center of reference for flow cytometers. So would be accessed by other young researchers?
Mm-hmm. Yes, well, the flow cytometer is located in a university facility whereby it is accessible to students, and students can come and we train them on the machine. They've come to appreciate a more user-friendly machine compared to the previous machines that were present, like a fax canto that was a bit complicated and limited in terms of running more parameters. Yes, so this machine is accessible, however, by the flow cytometer manager who trains the students. Thank you.
Okay.
May I add something?
Yes, please.
The number of graduate students from other universities also.
Yes.
Of graduate students from other universities come over to do their work in the department. That is really they're learning a lot. How to select panels for analysis. To use
Dr. Esther, maybe the next speaker is Neka. You may not be having a CV, do you? So if I may want to introduce Neka, who is presenting on multiplexed qPCR panels to differentiate clinically relevant Leishmania species using the bisulfite conversion technology. Neka is a PhD candidate at School of Life Sciences at the University of Technology in Sydney. She focuses on the development of diagnostic assays for Leishmania, and she has a passion for molecular techniques, and which she aims to make it accessible to the wider scientific community. So, looking into automation of lab services. And so she is a development scientist in Australia. She is affiliated with the Genetic Signatures Limited in Sydney. So Neka, the floor is you for next 3 minutes. Okay, we move on to the next one, which is Luciana Maria Cortez Macholino, Brazilian, who has graduated from biological sciences. And so she has experience in general biology, environmental education, and she had studied the polymorphism in birds destined for release, and a master's degree in biological sciences, cell biology, and focused on photodynamic therapy. It's another, therapeutic approach we never covered here. She's a doctorate in biomedical engineering for the University of Paraguay, completed in 2020. She's currently professor of basic education and 2 secretary of education, and she's committed to research. She's currently involved in her project that started with her doctorate, pursuing photodynamic therapy. Luciana, please proceed for the next 3 minutes.
Hi, my name is Luciana. I present the work on the title Analysis of Change in Mitochondrial Membrana Potential After Photodynamic Therapy in Leishmania promastigotas. Well, given the consequences left by tegmental leishmaniasis, the growing number of cases, and in order to mitigate the negative effect caused by the administration of conventional drugs, new alternatives such as photodynamic therapy have been studied. The PDT consists of using a photosensitizer that is excited by light at the appropriate wavelength, and this reaction in the presence of molecular oxygen produces reactive oxygen species, which can cause the extrusion and death of the target cells. The curcumin natural a low-cost dye, is being studied as promising photosensitizer. Therefore, this work wanted to evaluate the action of PDT on the mitochondrial membrana potential of Leishmania rheumaticus at 2 different times. After the process of PDT, the cells were incubated with rhodamina 1, 2, 3. After this period, the cells were washed for subsequent assembly of the slide, and their analysis took place under a confocal microscope. Then image fluorescence with quantified took the software image J. It was found that after PDT was increased the mitochondrial membrana potential, including the groups that receive only photosensitizer. In the analysis after 18 hours, the mitochondrial membrana potential was low at the highest concentrations in the only irradiated groups, with the exception of the graph D that was increased in the mitochondrial membrane. Demonstrated that light interact with the chromophore present in the organelle, causing change in the activity alter the testes. Demonstrated the high membrane potential does not mean that in the cells are alive, as it was found in previous tests that the cell viability of the two species was reduced, regardless of the time of analysis. This high mitochondrial activity might be related to the cell's tri-solver process. However, is the evidence the study involving the use PDT in Leishmaniasis resulted in change, and curcumina has been shown to be a good photosensitizer. Thanks for attention.
Thank you very much, Dr. Luciana. Do we have questions for Dr. Luciana?
No, we don't.
No? Dr. Luciana, why were you interested in curcumin? Do you have other photosensitive products, synthetic or whatnot? Why were you specifically interested in curcumin? Is there any other products that can be evaluated? You're muted, Luciana. Unfortunately, I can't turn on my microphone. Oh, okay. We have a problem with Luciana. Okay, we move on to the next presenter then, in that case. That is Aschalu, I guess. Aschalu Tamru, if you are with us, please be on the video.
Okay.
Yes, Aschalu is an Ethiopian. So he's a chief pharmacist at the University of Gondar Hospital at LRTC. He has worked in that center for 14 years, and so quite experienced in clinical trials. So, and he of course, a pharmacist, that's a nurse also, and a pharmacologist, and a clinical trial specialist. So he is in this opportunity. He has this opportunity to give us a wider perspective of what he does in his clinical trials. And so his main interest is like the tropical disease clinical research and diagnosis treatment included. And so he's, yeah, of course, looking forward for a PhD opportunity. And so Aschalu, take us through your presentation for the next 3 minutes.
Okay, thank you, Professor Asrat, and thank you for having me here to present my research work in this special event. So my presentation is on efficacy and safety of combination of treatment of sodium gluconate at 20 milligram per kilogram per day with upper maximum daily dose limit of 850 milligram and permazine 50 milligram per day in HIV negative Leishmaniasis patients. A retrospective study in Northwest Ethiopia. Please, the next slide. So to start with the background, as you know, BL is one of the most neglected tropical diseases and it's fatal if left untreated. And as per WHO recommendation of SSG has been in use without upper maximum dose limit at 850 milligram with PM since 2010. However, in some East African BL treatment centers, including University of Gondar, SSG dose has been limited to upper maximum dose. So there has been a debating, this has been a debating issue among experts as whether to use the upper maximum dose or not. And next slide, please. The objective of the study is to assess the efficacy and safety of 17 day injections of combined regimen of sodium gluconate and permazine in HIV BL patients. So methods, a retrospective analysis of medical records of BL patients treated in the University of Gondar Hospital during the period 2012 and 2019 was carried out. And next slide, please. So this flowchart shows the study population between 2012 and 2019. A total of 2,836 patients were treated, and out of this, 1,233 were treated with SSG and PM, and the rest, 1,603 were treated out of drugs out of other than SSG PM, either with ambisome, SSG alone, ambisome, and this group of patients were actually excluded from the outset. And only 1,000 participants from 233 patients treated with SSG were included. And the other 233 patients were excluded for reasons such as incomplete medical record, lost chart, and BL-HIV cases treated with SSG-PM. Next slide. So coming to the slide, actually I've mentioned these two bullets, and the median age of the study participants was 23, with the interquarter range ranging from 20 to 27 years. And 99.6% were male. Next slide. So 85, coming to the result, 85% of patients were seasonal migrant workers, and the rest were residents in the PL endemic areas. And then when we see the efficacy, the overall initial efficacy was found to be 92.2%, and treatment failure 3%, treatment interruptions due to drug toxicity should be added is 2%, default 1.3%, and this 1.5%. Next slide, please. So coming to the final treatment outcome, actually it was limited by the high lost follow-up, but we looked into patients 280 among 280 patients who complete 6 months follow-up. The initial cure was achieved in 93.9%, and relapsed 1.4%, and 13 of them developed post-kala-azar dermal leishmaniasis. And when we come to the safety issue, the most common adverse event was raised liver transaminase, which occurred in around 351%, which is 35.1%. And injection site pain and increased in serum alpha amylase was found to be 29.1%, and there are actually other AEs. So factors associated with poor treatment outcomes were okay. Sepsis, yes?
Please finish.
Okay. We also assessed the factors associated with poor treatment outcome. Sepsis, pneumonia, and presence of adverse events were associated with poor treatment outcome. Please next slide. And final conclusion. Next slide. So conclusion, a combination of SSG at 20 milligram per kilogram with upper maximum dose of 850 milligram, and PM was effective for achieving initial cure at the end of treatment and safe for treatment of HIV negative patients in northwestern Ethiopia. Our data are consistent with previous reports and confirms the effectiveness of SSG and PM treatment regimen in East African countries, and efficacy at 6 months was estimated on data derived from patients who completed follow-up and needs to be investigated by future studies. Thank you very much.
Thank you. Thank you very much. I guess this is a contribution, yeah, of course, on the current first-line treatment in the Eastern Africa region, the combo 70 days, and one of the latest studies. So it gives us confidence on the efficacy. Thanks for that. But any queries, questions in the Q&A? We don't see any queries in the Q&A. Or anyone? Yes, please.
I don't know if your study participants were over 45 kgs, and especially the ones who responded, because what you're finding in other regions, and especially in Kenya, if we have the upper limit for those who are above 45 kgs, which is the maximum, before we can go upper than the 850 milligrams, the response is not so effective. So I don't know whether you had those weight brackets and the response when you use the upper limit.
Okay. Yes, we have also patients weighing greater than 2.5 kilogram, and I didn't actually include it in this presentation, but we also tried to compare those patients with the efficacy of SSGPM for patients weighing below and less than or equal to 2.5 and above for 2.5 kilogram. And they were statistically, there was no significant difference between in the efficacy between the two groups. They were 90.2 and around 90.7% for those less than or equal to 2.5 and greater than 2.5 kilogram.
Okay. Yes. You can talk maybe.
Oh, what is this name?
You can just give it here.
Ask them, did you encounter any antibacterial side effects of SSG, any kind of toxicity, notably in the evidence? Thank you.
Okay, regarding efficacy, I actually tried to mention the most common ones, which is raised liver transaminase, which accounted 35.1%, and also the injection site pain and raised in serum amylase, which accounted 29.1%. There are also actually other adverse events which were not very common, like clinical pancreatitis. Cardiac toxicity was also noted in some 6 patients, and nausea and vomiting are actually the most common one, but they were not actually depicted in our, was not the finding in our study. There were few numbers at least.
Thank you, Aschalo. We're done with this presentation. We move on to the next one. Let us know if Dr. Dawit is here with us. If not, then we move on to Dr. Kumar. Dr. Kumar, okay, so Dr. Kumar is the PI of the project on the role of adenylate cyclase of L-donovani on host immune modulation in visceral leishmaniasis. And this has been a project funded by ICMR in India, New Delhi. And he's also a PhD student and almost submitting a thesis in Calcutta. So Dr. Kumar, he holds and M Tech is the biotechnology from Maluna Abul Kalam University in West Bengal, in Kolkata and India. And this was from Dr. Rajendra Prasad University in Bihar. His research interests are parasite immunology, which is important, oxidative stress, and cellular signaling. And he has earned many awards and published many articles in several journals, and also has made several oral presentations. Dr. Kumar, the floor is yours for 3 minutes. Kumar, Dr. Kumar. Apparently, it's not here, I guess.
Was there?
30 seconds. Okay.
That is a slide. That is in the slide.
That is the last one, or?
Yes.
Yeah, good. But I don't know what's happening. Well, Dr. Esther, I'm afraid Dr. Kumar doesn't seem to be with us. We thought he was here.
Just dropped off. I think we can't wait.
Okay, we wait maybe for another 30 seconds. Jane, do you want to say something now? Because this is the end. Do you want to say something about the Kenyan?
Is he still there?
So any housekeeping? I think
he's good now.
Yeah, we're sorry for the audience. We seem to have lost Kumar, and but the title has been displayed, so it would have been nice to listen to his talk, but unfortunately we are unable to do so. But this is the last part of this session. The two sessions together, in the CL section and then the oral presentations. And we are thankful for all presenters and the audience who are also online and listening carefully and asking questions. We thank everybody, and I thank my co-chair, Dr. Esther, and the presenters again, and thank you very much. I'd like to see you tomorrow again. Thank you. The session is closed.
Thank you.
Thank you very much.
Yeah, thank you. Bye-bye.
Yeah.
Was this the scoring? Was this the scoring?
What scoring?
Scoring the poster.
You have to do it. Yeah, you have to score. Are you doing it? Yeah, you have to score. You have to score.